morning, Dr. Agnes.
Good morning, Dr. Sukat. I hope you can hear us.
Yes, very well.
Good. Welcome. Good morning, everyone. I'm glad you're able to make it to this our pre-conference session. I'm not sure if we can project anything from any screen. Is there any screen that projects agenda or something? So that others can as well see. I'll just be talking to it. We have a very full agenda. Sorry, we're starting a little bit late. We have been running this thing for quite a while, thanks to support we've gotten from partners. We have our partners also well acknowledged. You can see as part of the AfHEA, but specifically for the group that we put together to work on developing and curating health economics curricula on the continent, specifically for postgraduate studies. We figured out that over the years, different countries and universities and training institutions come up with their own health economic curriculum. For us, it is good. Challenge is that most of the graduates that are coming out of these programs are not necessarily ready for either the industry or even in academia or working within government and other parastatals. The demand from these absorbers of labor does not match what is being supplied by the training institutions. One that became obvious was the lack of connectivity between reality and what they are being taught at school. Many of the things that were taught are pretty much abstract and tend to follow the traditional learning approach that has been there since ages, which we all know a lot about the relics of our colonial past still lingers. And so what we did was to put together a team of experts across the 5 regions of the country, from North, Central, East, West, and Southern Africa, to look at curricula, health economic curricula on the continent, and also keeping an eye on international developments to come to pretty much a consensus, if we can, to have a set of I'm not sure where the echo is coming from. Okay, someone wants that. If you can mute. Not hopefully when I hear myself. The echo is coming.
So somebody that has joined online for the interpretation hasn't plugged in earphones already. So
you joined in for interpretation just now. Please, you can change your audio setting to your microphone, mobile microphone, or hardwired one. I think we're good. Great. So let me come back to where I stopped. So we realize there's a mismatch between what is being taught and what is demanded from industry, from government, and also from international organizations as well. The relics of colonialism still lingers. I mean, the sense that many of the topics are pretty much aligned with what we have known from our great-grandparents till today. So the team did an excellent job, I would say, to look at curricula on the continent and beyond, to curate, especially for masters in health economics. We figured out that in many universities, health economics can be taught at the School of Economics or Department of Economics. Health economics can also be taught at schools of public health. Some universities and training institutions also do health economics training via the schools of business. And some have a hybrid of having some people training at the School of Economics or Department of Economics and later on joining with the schools of public health or community health or whatever it's called in various institutions. So we had this thing of trying to have a balancing, to balance the scale in such a way that we touch on economics, because health economics is a branch of economics, as well as situated within public health, because health economics is economics as well as trying to find solutions to issues within the public health or the health system space. And so it's important to merge both worlds. So what I'm trying to introduce here, according to what I've been told to do, is to welcome everyone. So I take this opportunity to welcome you. I'll talk a little bit about the objectives of the workshop or the meeting or a session or conference, whatever I want to call it, in a while. So I take this opportunity to welcome you and for you to have at least chosen this amongst other competing priorities. Indicates, I'm speaking as an economist now, at least it kind of indicates the value you put on this, and we appreciate that. We'll make this very open and people are free to kind of contribute. For those of you who are here, interpretation is available. You just need to download an app. If you've not downloaded the app, you can raise your hand. Then I don't need to go over this. Okay, good. Before downloading, so it's good. I'm not going to go there anymore. So you can always tune in and listen if the language being spoken is the one you don't understand. AfHEA is bilingual. We do French and English. Unfortunately, we're still trying to get into Portuguese, Spanish. We have them on the continent. So thank you very much. I will quickly want to welcome Dr. Nadia Yakalev, who is currently the head of the Division of Health Economics and Financing at the Africa Centers for Disease Control and Prevention, headquartered in Addis Ababa, Ethiopia. She will be welcoming you as well and giving a brief intro to what they do as well at Africa's Centers for Disease Control and Prevention. So without further ado, Dr. Yakalev, if you can hear me, please chime in.
Good morning, everybody. Yes, I hear you very well. So, honored guests and dear colleague, I am very sorry to not attend in person to this important side event, but it is a great honor and a true pleasure to be with you today, even virtually, to mark a key milestone in strengthening health economics capacity in our continent. We are here today because we share a strong conviction. Health economics is a strategic pillar to ensure more resilient, efficient, and self-sufficient health systems in Africa. Africa CDC, through its Division of Health Economic and Financing, has made it a priority to support African Union member states in structuring and optimizing the financing of their health system. Too often, our countries face major financial challenges that hinder universal access to healthcare. In response to these challenges, it is important to strengthen local expertise in health economics so that African policymakers can develop financing strategy tailored to the reality of our continent. With this objective in mind, Africa CDC and the African Health Economic and Policy Association, AfHEA, initiated the creation of health economics curriculum in May 2024. This curriculum was developed by a working group composed of African academics and policymakers and is designed to address the concrete needs of our countries. It includes several levels of training: master's program, diploma, short courses, and fellowship programs. The foundation of this program was laid during the first in-person meeting of working group in Accra on June 2024. This was the pivotal moment that allowed us to define the term of reference expectations, and key thematic areas of the curriculum. Since then, through monthly follow-up meetings, we have steadily progressed toward its full development. The second in-person meeting was held in Kigali on December 2024. This meeting helped refine the content and incorporate expert recommendations. More than 15 specialists participated in this important step, working closely with the University of Rwanda and the Regional Health Economics Policy and System Center hubs. Thanks to this collaboration, we now have a comprehensive and finalized curriculum. This program is critical for Africa. Indeed, Africa faces complex health challenges that require strategic decision based on a rigorous analysis and evidence-based approaches. Too often, due to a lack of local expertise, our countries adopt imported financial models that are not suitable for our need and priority. This curriculum aims to change that by empowering African countries with health economics experts capable of designing, evaluating, and optimizing sustainable and equitable financing strategy. By training a new generation of specialists, we aim to enable governments to negotiate health budgets more effectively, maximize the efficiency of investments, and ensure better at scale healthcare accessibility for all. We no longer want to be passive recipients of financing models created elsewhere. We want to be the architect of our own health systems. A project of this scale will not be possible without a strong and commitment support. The French Development Agency, Agence Française de Développement, and the World Bank have played a key role in funding this essential initiative. And I would like to extend a special mention to Dr. Agnès Souka, the Director of the Health Division of Agence Française de Développement. Dr. Souka, your constant support and dedication have been key in making this project a reality. You have always supported our division with a clear vision and strong determination to help African-led solutions succeed. Your trust and support mean a lot of us, and we are proud to have you as one of our key partners. We also extend our gratitude to AfHEA for its strong commitment, as well as to our technical partners, including CHAI and Spark. We have provided invaluable assistance through this process. Today, we have reached a key milestones, but our work does not stop here. This curriculum must now be implemented, expanded, and adapted to meet the need of African countries. Its success will depend on our collective ability to bring it to life, promote it, and turn it into a sustainable tool for transformation. I wish you a fruitful and inspiring day of discussion, and I look forward to the progress we will achieve together. Thank you very much.
Thank you so much, Dr. Yakelev. That was very interesting, and we are really privileged to have you on board at the helm of the AfHEA CDC, Health Economics and Financing Program. On our agenda next, we have a brief same welcome remark by Dr. Agnès Souka, who is, let me get your I don't know the exact designation, but I'll let you introduce yourself more than I can do. I know if you've known Agnès, she's a figure in health financing globally. She's worked in many organizations, and now she is with the AfD, which is the French Development Agency. So without further ado, I will give the floor to you, Dr. Souka, to give your welcome remarks as well. Thank you so much. Dr. Sukat, can you hear me? Can someone drop the chat? Maybe she's not mute, she's unmuted, and the usual challenge. If you are muted, please let us know. Oh, she dropped off. Okay. Unfortunately, I think she might be having some technical challenges. We'll give her the opportunity whenever she comes back online to give her remark. I think that is pretty much it. What I would like to do is, I know we have a lot of people here, so it's not, is she back? Okay, good. Sorry, I'm not keeping an eye on what's going on there. Dr. Agnes Sukat, if you can hear me, if you can give a brief introduction and give a welcome remark, that would be good. Thanks.
Thank you very much. And hello to everybody. It's nice to see all these old friends around the table and some new friends also. It is really my privilege to be here this morning with you. I feel very honored, and I feel really that Nadia, you've been very, very kind in your introduction. I think we would like to do much more than what we are doing to support health economics and health financing in Africa. And this is the first thing I want to start with this words of introduction, is really to thank all of you that are dedicated to this cause. We know in today's world, this is complicated. It's complicated to promote evidence-based and science-based solutions. The world is questioning a lot of the old policies. You mentioned in the introduction, you mentioned the question of colonization. And I think we need to face this in a very straight way. We need to carve new pathways for the future, and they need to be grounded in the African experience. It is really, for me, very exciting, and it's a privilege to be able to contribute to this movement. This is something I've been very dedicated on doing for many decades now, on really building the capacity in Africa for conducting analysis, and particularly economic analysis that is grounded into the reality of this country. So I really welcome this initiative. We've been very excited when the unit of health economics was created in Africa CDC. We think it's absolutely essential, and of course, we've been supporting AfHEA certainly in other capacities before. For me, this has always been an organization that is really dear to my heart, but now happy to support it directly from where I am now in the France Agency for Development. The France Agency for Development has completely reshaped its global health strategy and policy in light of the lessons learned from the COVID pandemic, but also learning from decades of experience in working on health systems in Africa, and learning from you and from the countries about what works and what works less well, in working at developing domestic policies that contribute to understand better the use of public money, and how we can crowding also private financing into health systems. I'll finish this short word of introduction by saying how important I think health economics are. But important, yes, but we also need to rethink how we promote this agenda in Africa. Yeah, there is certainly the question of an agenda that has been driven from universities abroad and now needs to be owned by a strong network of academic institutions in Africa, and there is a lot to do there. There is already a lot happening. We know what's happening, in South Africa, in different institutions. We know what is happening with KEMRI in Kenya. We know what's happening in Senegal and elsewhere. But we need to do much more in bringing academia and the Department of Economics of all countries in Africa together to shape this agenda. My second point is about what we do. We know that the field of health economics has been very influenced by some sub-technical technical sub-areas. One of them, a major one, being the work that has been championed on questions of cost effectiveness and benefit packages, which is at the heart of health economics, because we know how important it is to make the right choices in what is financed in health and public health. However, we've learned that this is only one sub area, and there are others that are often neglected. And some of these, which I think are particularly important, is the whole question of expenditure tracking. Not only thinking about what would be theoretically the best investments, but also looking at whether actually the money is flowing towards these investments. And there's been a lot of progress. When I was at WHO, we invested heavily in national health accounts, which has really the advantage of promoting the production of data at country level, whether it's production of public expenditure review data, public spending data, but also production of private expenditure data through household surveys. And I think we need to do more on that. I was really saddened recently by reading the WHO report this year on NHA that showed that less countries are reporting now than they were in 2019. I think there's been a big shock on our data systems during the pandemic, and not only a very strong recovery after that. And this is why organizations like Africa CDC are so important in this agenda, because it is about generating economic evidence, and particularly, as I mentioned, this example of expenditure tracking. Generating economic evidence is extremely important if we want to actually have a sense of reality on the ground and what is happening on the ground. And sometimes people wonder, why is Africa CDC involved in health economics? And my answer, it's really because it is about evidence. It's about evidence on how governments allocate funding, but it's also evidence on how households behave and how they make decisions on health, and how we link behavior with health investments and the whole question of behavior economics, which is very important. And that also sort of brings me, I mentioned expenditure tracking, but there are other areas of health economics which in a way have been neglected in Africa. Behavior economics is one of them. Others, I would say, is the whole question of the macro impact and the role of health services and the health sector in the economy, in driving the economy. We know that this is the case when we see that the largest economy in the world, the US, the United States of America, has 20% of its economy driven by the health sector. 20% of GDP, and worldwide it's 10%. And still, there is a discourse as if health services would be some kind of area that is limited to social public spending, while it is actually an economic sector. And we see it very, very much in the African continent. It's certainly, for example, very much the case in South Africa, where private health services are a big big chunk of the economy. But we know it's true everywhere, and we know it is growing. So I'll finish with my last point in a concluding point, which is that I think this group is extremely important. What you're doing is very essential to the future of Africa, not only the future of health and knowing better, generating the evidence and the understanding on how economic aspects and economic drivers shape health, but also how the health sector and the production of health does shape the economic future of Africa. So I'm wishing you the best of luck in this endeavor, and as much as I can, I'll be at your side and with the France agency, the AFD group, trying, really doing all our best to support you. Thank you.
Very, very insightful remarks there. Thank you so much, Dr. Sokat, as always. And it's a pleasure that AfHEA also partners with AFD and has been one of our anchors, especially for the conference. And so we appreciate the AFD. Thank you so much. We are pretty much continuing the rounds of intro, keynote speeches, and the next on our agenda is Dr. Matiko Riro. Matiko Riro is one of us from Africa here, and we are proud to have him at CHAI, Clinton Health Access Initiative. He's based in Nairobi. He will talk more about himself. Like I say, people know themselves better than I do. It would be a crime to know somebody better than themselves. A social crime, actually. So without further ado, Matiko, if you can take the floor and give us a few words. Thanks.
Thank you. Thank you, John. And thanks, everyone. Welcome to this session today. So as John mentioned, I'm Matiko Riro. I work with the Clinton Health Access Initiative as the Associate Director for Health Financing. And in this piece of work, which we've essentially been working on for the last couple of years, and I know maybe many people have come before me that have been talking about this in terms of how can we build and strengthen health financing capacity in the continent. And for us, it's CHAI, because we work quite closely with the government. One of the key elements that we've been thinking about is how do we use the government as the sort of the starting point of this transformation that we're talking about. And to do that, then we have to first go ahead and identify what those gaps are in the government and actually address them using very context-specific, Africa-centric, approaches that we're going to use. So a couple of years ago, about 2 years ago, we had a landscape assessment across 9 countries in Africa around the health financing capacity in the continent. And one of the key things that came out is quite diverse in terms of what the different gaps are, be it at the National Health Insurance Agencies or the Ministries of Health or Ministries of Finance. But also even acknowledging that that capacity sometimes might not be the individuals, just how the institutions are arranged to optimize on those capacities. So for example, I know a number of countries that will agree with this, is the Ministry of Health does not actually have the power to hire. Hiring in most countries is centralized in the Public Service Commission or Federal Service Commission and all that. So even the Ministry of Health power to change and move certain things become a challenge. And so even as we talk about the capacity and some of the bits that we're talking about, it'll also be interesting to acknowledge some of that and see how do we strengthen the many players that work within that. And even within that, one of the things that came out is even the Ministry of Health, if you look at the economists or the planners, in most countries they're seconded from Treasury. And so how do we engage those two, that sort of institutional arrangement? And even within the growth structures, most ministries of health do not have this whole element called a health economists, cadre within the Ministry of Health. And so even as we talk about this, it would also be important for us to see how then we shape even the institutional arrangements to optimize that. And even, so that being said, there's also a challenge in terms of the relationships between the Ministries of Health or generally the government and the institutions of learning, in terms of how do we communicate to each other in terms of what they need, not only in terms of the capacity, but also the research agenda. How are we informing that we need this at the Ministry of Health, and then that's how the response we have at the institutions of learning. So that sort of communication are some of the things that we have to be quite aware of. And so even as we talk about this, as we talk about the curriculum, and I know we're going to talk extensively about this, we've been working quite closely with the team at AfHEA, Africa CDC, and the different technical working groups for the last 1 year. You know, we've had a couple of workshops physically in Accra, here in Rwanda, had lots of that virtually. To be interesting also to get feedback from the broader perspective in terms of what are some of the things that we could be missing. And also acknowledge that some of this, you know, as much as we're talking about it from a very academic angle, what are the voices of the policymakers? How does it respond to the needs? Because we could be talking about it, you know, very high level, but actually what some of the countries need is just someone to run Excel, you know, Excel models to enable them learn about this. It's really about someone having good communication skills to communicate what the government, what the Ministry of Health and Finance can negotiate in terms of that. So it would be good to hear more from the teams that are here so that we can, you know, come up with a more robust sort of approach of building capacity in the continent. So really happy to be here. You know, it's work that I'm happy to be part of, and really happy to have all of you in the room, and we're looking forward to talking through this today. Thanks, John.
Thank you so much, Dr. Riro, for, again, a very insightful remark. And like I said previously, we've had engagements with CHAI and have been privileged to be supported by CHAI or through many initiatives we have engaged in, including this. So it's a pleasure to always have you on board, Matiko. The next person on the agenda, I know we have tea currently being served, and it's going to go on until 10:30. So I would like to have the next speaker, Dr. Boniface. Okay, yeah, good. I was always looking this way. I never looked like this to see who's there. I want to welcome, I hope I can call your son name very well. I struggled with it, but I will try. How do you call it? Yeah, I was thinking that I shouldn't be there. What I put in the idea in. Okay, Dr. Butia Boniface, who again works with SPAC. SPAC is, I like not calling acronyms, but I will try to explain. SPAC is, he will do better than I do, is the Strategic Purchasing Africa Resource Center, and also AMREF. We're talking about AMREF. Without further ado, I'll give him the floor to give a few remarks. So you're the one standing between us and tea break, so it's up to you.
Thanks, John, and good morning. It's with great pleasure that we come together to discuss key issues around how we can build the capacity of health economists and healthcare financing specialists, you know, across Africa. But I wanted us to just start with one common saying that would be able to characterize what we are going to be talking about today. And it was said by Victor Hugo, who said, the most powerful thing is an idea whose time has come. And we strongly believe that idea of building capacities of African specialists in this field is an idea whose time has come. So that we don't beat about the bush, but we ensure that we provide the right technical and soft skills that would be needed to navigate the extremely difficult field of getting resources for health. But after getting resources, then we need to think about how do we use those resources to affect the health outcomes for our people. And this journey has been, or rather has been a collaborative effort of multiple partners. And it is important to realize that for us to be able to make any meaningful gain, unity of purpose needs to continue being part and parcel of how we carry out the business of the day. And when you think about Africa and you think about this particular field of healthcare financing and health economists, it is important to realize that we need to have our eye on two spaces. One is that we need to put our eye on the wider system to get to understand how is the wider system affecting the smaller system within the health sector, and how do resources get transferred from the wider system to the health system. And I think part of those are the discussions that we need to be able to keep looking at. Second thing that is important is to ask ourselves, how will we help specialists in this field to be practical in approach, but also ensure that as they speak to their counterparts in the wider system, that one, that they are confident, and two, that they are able to share evidence-based arguments that would then be able to ensure that there is synergy in terms of the purposes that we are seeking. Our experience as AmRef Health Africa has been interesting over the years. Looking through at the differences in capacities, for example, between the Ministries of Health and National Health Insurance organizations, and noting how sometimes the differences in capacity limit progress in this particular area. There are few countries in Africa that you could isolate, where you would say that the Ministry of Health can give clear directions to the National Health Insurance systems. And it's important that we are able to help unravel some of those. What about the subnational units? A lot of responsibilities have been allocated to subnational units, but what's their capacity to be able to negotiate and navigate through the discussions that require money to be transferred from the national level to the subnational level, and ensure that they can be able to then be translated into improvements in health outcomes. And so when we talk about this curriculum, we need to keep reflecting on the magnitude of the responsibility that is at hand. Because we are basically saying that our 54 countries in Africa have an opportunity of responding to emerging issues. Today, I'm sure that you cannot speak about healthcare financing without talking about the changes that have occurred in financing of healthcare, especially with the changes in the USAID. But the issue is, what are we going to do after this? Will we go back to USAID and ask for more funds? Or will we reorganize ourselves and see whether there is money in our systems that we can begin to address the common health problems? And so when we talk about this curriculum, we're not just talking about a one approach. We are talking about a multifaceted approach that will help the specialists that we are building capacities for to then help us negotiate and to be really hard negotiators, as it were, that will then help to transfer resources from the wider system to the health system, but also help the system to transfer benefits to the wider system. AmRef Health Africa has been around for the last 7 decades and has begun a lot of work around healthcare financing. And through that experience, we have been implementing the Strategic Purchasing Africa Resource Center over the last 7 years. It's important to see that over time, we have been able to appreciate a few things as we have interacted with different countries in Africa. One is that when we think about reforming the health system, sometimes reforms could be slow but sure. Some of them could be fast and then could also be reversed. And that means that we have to keep helping the specialists that we are bringing up, that there is no one way to get to where we are going. And we have to be alert about what is happening. The second thing that is important is to realize that there are fundamental small changes that are needed that will then contribute to the wider change that we are seeking. And so as we join together with other partners in supporting this effort, we are happy that the journey has begun. But we are also happy that there is a good future and very good prospects, as it were. Allow me to end with another final statement that is drawn from Ethiopia, one of the countries that we have a country office in. And the statement said that eat when the meal is ready, speak when the time is right. And I think that's the kind of discussion that we're inviting all of us to get into. Thank you very much.
In fact, the meal is ready. The meal is ready. Thank you so much, Dr. Boniface. I think this is also very insightful. And we have had extensive collaborations with AmRef and SPAC as well. And we would like to see that collaboration continue post now, basically. A lot of things have been said, and I wish I could summarize them. But we are already eating into our lunch, our tea break. Early lunch. But before we go for lunch, bear with us, we would have about 10-15 minutes for lunch. There are people who are online, who we have not been able to engage with them. I'm not seeing them. So please don't think that we've forgotten you. You're not a forgotten group. You're pretty much alive. There are questions that have been posted on the chat box. If you have more questions, please put them in the chat box. We'll collate them and talk to them. There's one I want to highlight, which was asked directly to, I think, Dr. Nadia, and everyone, actually to everyone. I don't know who asked the question, pardon me. I would just say the question in English for participants. It's written in French, but I would say it in English, especially for the benefit of those who cannot speak French directly. So it just basically says, hello, everyone. Thanks so much to Dr. Nadia and Agnes for their present interventions and presentations. The question is, how will the training programs that have been talked about by the different presenters be so inclusive such that it can take into account all the countries, including Mali? So the person already, you could tell, is coming from Mali, I guess. So they are interested in Mali, because without the inclusion that allows us to enhance the capacities of countries together, we will always have difficulty playing an important role in certain countries. So it is also a question of promoting the representativeness of all the contexts in terms of human resources in national and as well as international agencies, including Africa CDC. I don't know who wants to go with that question, but maybe Dr. Nadia and Dr. Sukat, if you're still there, you want to speak quickly to that?
Yeah, sure.
Yes, for sure. So the question is in French, so I will answer in French. Donc merci en tout cas pour cette question qui est vraiment essentielle. Effectivement, pour que ces programmes de formation soient réellement inclusifs et bénéficient à tous les pays, y compris le Mali, il y a effectivement plusieurs pistes qu'on doit explorer. D'abord, peut-être dire qu'il est important d'impliquer déjà les pays dès la conception effectivement des formations pour qu'elles répondent vraiment aux besoins spécifiques de chaque contexte. Ensuite, effectivement, l'accessibilité est un enjeu clé. En plus des formations en présentiel, un cours en e-learning sera disponible, ce qui permettra de toucher un plus grand nombre de participants malgré les contraintes logistiques. Enfin, effectivement, la question de la représentativité est essentielle. il serait intéressant de voir comment ces formations peuvent aussi favoriser une meilleure intégration des talents locaux dans les organisations nationales et internationales comme le CDC Afrique. Effectivement, l'objectif est d'assurer un renforcement des capacités qui profitent réellement à l'ensemble des pays de la région. C'est tout pour moi.
Thank you so much,
De mon côté, donc, si vous voulez, je continue en français sur la même, notre collègue du Mali. Je crois que ce qui est essentiel pour que cette formation soit vraiment à la destination de tous, c'est vraiment de travailler avec toutes les institutions africaines régionales. Donc, je suis tout à fait d'accord avec ce qu'a dit Nadia. Je ne répéterai pas ce qu'elle a dit sur les aspects techniques de la formation. Mais ce qui est vraiment essentiel, c'est d'avoir donc une adaptation aux différents contextes des différentes sous-régions de l'Afrique et de travailler à la fois avec les institutions académiques, des associations comme AfHEA et des institutions régionales et sous-régionales. Il s'agit vraiment de développer ce cours comme un bien public régional pour que tous puissent se l'approprier. Merci.
Merci beaucoup, Dr. Sukat et Dr. Yakalev. What we will do now is, I wish I could add more to this, but the challenge is the tea break. So because that is fixed, I cannot necessarily change that directly. So maybe we'll break for tea and come back. Then I will talk more about the objectives of the meeting, as well as also highlight or try to answer some of the questions in the chat box, including the one just touched on by our panelists. So without further ado, I would invite you for tea, and we will reconvene here. Oh, Dr. Matiko has a...
Sorry, I mentioned a question here.
Okay.
I referenced the report that we did 2 years ago. So we'll be launching it tomorrow morning, same spot tomorrow. So for those who are here, you can feel free, you're welcome tomorrow, same spot.
Invitation. That's an invitation.
Invitation.
Good. Okay, great. Since the time is there for till 10:30, the tea will be served until 10:30. I will only have about 10 minutes. And so you can grab the tea and we'll be back here at 10:30. I think 10 minutes should be fine. Okay, housekeeping. There are two places where tea is served. One is just very close to us, pretty much opposite. And then one is to your, if you step out to your left, you go down you go round, kind of a round building. And so you go around, it's somewhere you can locate it towards the end on the other side. Thanks. Feel free to choose anyone, all the same. Very, very important thing we're doing here. I will now pretty much move into the technicalities. Kind of done with the introduction, speeches, and let's get our hands dirty into the real deal in terms of the curriculum we're talking about. But before we start, I would want to give you a quick overview of the objectives, and have my colleague, Dr. Elias Asbau, joining us as well to give a presentation on the kind of progress that we made so far with the curriculum development, and where do we go from there, basically, or what do we expect going into the future. And we'll touch again on some of the questions that were raised earlier. I don't know whether there are more in the chat box. Are there more? Okay, no. But that one that was raised earlier about making sure that we have representation across Africa is very important. and it really sits at the heart of what we do. We kept asking ourselves, are we representative as enough? And when we were challenged by North Africa, we reached out actively, trying to find at least a representative from North Africa. That's why we have a very good colleague here. So we have people representing the different parts of Africa. So Mali, we're now dealing with West Africa. And within West Africa, we know there's a split between the Francophone and the Anglophone. Unfortunately, we cannot represent all countries because we only have about 5 or 6 seats. So representing all countries, 55 AU countries, it's going to be very difficult. So we have someone representing the Francophone West Africa from Senegal. And that was deliberate because of CESAC, which is a training institution in Senegal that has trained a lot of people in the region. And we have a colleague here representing French West Africa. There are other people representing different constituencies, which I don't necessarily need to mention at the moment. The core objectives, I don't know whether I even introduced myself, but I just assumed, I just started talking, which I just realized, which is something I do very often. I just go straight to talking. But I'll just basically introduce myself. I'm John Ataguba. I have a day job in Canada at the University of Manitoba. And I also have a job at AfHEA as a chief chef, pretty much the chief servant, I say, of AfHEA. So it's a pleasure to all have you here joining the conference. And importantly, we are here for the curriculum on health economics. The key objectives are pretty much things we already know. One is to take a look at what we've done so far, whether we've done a good job or not. We want to hear from you. There are things that we may have missed, honestly, and we'll rely on you as experts in your different areas or niche to make contributions to discussions. Importantly, we want to leave here, which I'm pretty much dabbling into what my colleague is going to say. And we want to leave here with kind of feeling that we have some agreement or some kind of unification or harmonization of the curriculum and that we want to broadcast to everyone. So it's a product of the product for everyone, product of Africa for Africa. So we're not doing this and keeping it to ourselves. We're doing it for everyone. It's going to be open source. So if you want to begin training in health economics in your country or institution, you're free to take hold of the curriculum, adapt it to your own circumstances. If that's enough. So I don't want to speak too much because we run out of time. We want to dedicate a lot of time to the main content of the curriculum that we developed. I want to quickly hand over to my colleague, Dr. Asfal, who will talk about the achievements, milestones, and what are the key steps going forward. Thank you.
So sorry, John. Maybe it's good to have the introduction. That would be ideal. No. Just a brief. No, it's just for that.
Okay, sure. Yeah, that's okay. I'm having a very good suggestion here for my colleague that we don't even know who's here, who's not here. And given that this is as opposed to the traditional kind of conference setting, we might want to even know who's here. Just by a very brief introduction, so I will not spend another 30 minutes through your long bio. Like I give my bio immediately. I'm John. I have a day job at the University of Manitoba in Canada. I'm also the chief servant of AfHEA. I think something of that nature. Thanks. Usually I like starting with women, so I don't know where I'm going to start. Good.
Yeah. No, you share. Share. Yes, share.
What's one there? Because no one knows.
Share. That is you.
I'm Suleiman. I work from University of Rwanda, and Department of Politics. And then we are starting this curriculum. And we are collaborating with us under the African CDC.
Okay, my name is Felix Obi. I'm Nigerian, as you can see. I am a member of the AfHEA Executive Committee, and day job, I'm the country director of Results for Development in Nigeria. Thank you.
Good morning, I'm Regis Sintmana. I work for the Rwanda Social Security Board as Chief Benefits Officer. And I've been working with the University of Rwanda to launch the same curriculum, but also I'm part of the committee that has been working on this curriculum, and I'm bringing the policy expertise in this committee.
Hello everyone, I am Abdul Minister. I work with the Health Policy Research Group at the University of Nigeria.
Hello everyone, my name is Dr. Masungai. I come from Senegal. Is that South African University the same department. My name is Gordon. I work for AfHEA Africa. And I also lead the
Hello, I'm Rosemond. I come from Burkina Faso and I work in a health research institute.
Good morning, everyone. My name is Patrick. I am Cameroonian researcher. I'm working on bargaining power of African economic system. Thank you.
Good morning, colleagues. Chike Zefa introduced my name. I work with Veritas University of Abuja, Nigeria. Thank you. Je suis Gassel. Je viens de Côte d'Ivoire. Je suis pharmacien. Je suis professeur d'économie de la santé du médicament du système de CAMES.
Morning, my name is John Kakane. I'm from the University of Rwanda.
Good morning, colleagues. My name is Shukri Arfa. I'm a professor of health economics at the University of Carthage with different roles in WHO, WHO, and now working with in relation with the desk WHO in Arab Emirates.
Good morning, everyone. My name is Elias Asfau. I work with the Africa CDC in the Division of Health Economics and Financing almost for the last 4 years from the inception, and I'm the focal supporting the health economics work from Africa CDC. Thank you.
Good morning, everyone. My name is Satah Prabhuwatan. I am the secretary to the working group for this curriculum. Thank you.
Yeah, so my name is J.C. Uzochukwu, South Public Health Systems and Policy, University of Nigeria, Policy Research Group, a foundation member of AfHEA.
Good morning, everyone. I'm Aisha Adamu Abubakar, from the Swamp Coordination Office in Nigeria. My name is Shamit London, and I work for Tribe.
Are you speaking of the micro?
Yes. Bonjour à tous. Je m'appelle Sangaré, enseignant-chercheur à l'Université Félix Houphouët-Boigny, Côte d'Ivoire, ministre de la Santé. Je suis à l'UFR de contrôle stomatologie, la chirurgie dentaire.
I speak of repeats.
Good morning, everyone. My name is Sanay Karamayo from Vietnam, working from Good morning, everyone. My name is Mariana Post. I'm Mozambican, and I am an health therapist, and I work as an independent. My name is Melissa. I am Janet Jurts, Laura, so many Western Africa, awakening
Good morning, everyone. My name is Emmanuel Mori. I'm Tanzanian. I'm at the University of Leiden, section for ethics and health economy. I had the establishment of the policy center.
Wow, thank you. That's really good. Yeah, good. So I'm Mati Koriro. I work with so as I mentioned earlier, it's part of this conversation, building, strengthening health economic capacity, and really looking forward to this conversation.
So you work with chat. So you're not going to give us chat. Having chat.
Yes. Yes. Good morning, everyone. This is in Rwanda. I currently work at the Ministry of Health. I will be a beneficiary of that.
Good morning, everyone. I'm Natea Bora. I'm a medical background from Tanzania. I'm currently a PhD student with the Global School of Tropical Medicine.
Great. We missed so much. Two people today. And let's start with women first. Introduction. And yes.
Good morning, everyone. Chairman Yami, academic staff from the Rwanda, School of Public Health, and Management. I was one among who developed the health economics, master's health economics in course. So I'm glad to be here and excited to learn more about this.
Welcome. Like we say, our community doesn't end here, even though it kind of started here. We have a community extending online as well. So for those of you who are online, we've not forgotten you. You're not a forgotten group. Feel free to drop a bit of your bio. I am these. I work at wherever you work as a way of introducing yourselves. There are those who can also log online to see who's connected. So thank you so much and welcome to our sessions. Without further ado, are you ready?
Sure.
I'm giving the floor now to my colleague, Dr. Asfau, who will do a brief presentation. Thank you.
Thank you so much, John. It will be a very brief, but we should have to give you the context and the background so that what we achieved so far, what is the next step, so that we will go together, right? So that is the intention, and then I'll be very brief to take you through the process, especially from the Africa CDC, what is our plan and how we are strategically joining with AfHEA, which is a regional organization composed of different academics as well as the researchers, and then what think it's moving on this. Okay, sorry. So I think basically the health economics division within the Africa CDC has three main areas, and it was established in 2020. And then the aim is to build the capacity of because we need to have a solid capacity, especially for member states, in terms of different ways. And then you can see the curriculum work is one of the strategy that we are pushing jointly with AfHEA. The other angle where the health economic division is pushing is evidence. That is the evidence generation and mobilization. We know academic institutes also, they do have that capacity. So we need to, should not have to duplicate efforts, but at least being a regional institute within the Africa Union, which is a political space, we do have that leverage and mandate. So we are thematic areas during that meeting, where how are we going to strengthening the regional health economics and financing capacity in Africa. So I'm sure most of you may attend that session. So during that, we highlighted the 5 thematic areas in that document. One, we need to work on the demand creation and advocacy. And then the second, capacity building. The third, knowledge socialization. The fourth, professionalization, networking. So we already unpack all these 5 areas. We do have a detailed joint work plan. And then we should not start, I mean, because of the resource and everything, we start from one area. So we pick the capacity building, and then we start to work on the health economics curriculum work jointly with AfHEA, so that we will expand also to work on the other spaces, so that we will have a solid health economics capacity within the continent. So I think it's already well said by John and the opening remarks. We established the health economics curriculum working group comprising academics and policymakers, especially to curate and guide the development of the harmonized health economics training curriculum for different programs. So I think my colleague, Dr. Yao, he will present the detail from the master's, short courses, and some fellowship programs. And then we are aiming to have it much more an open source, so that it will be a live document. So any universities, depending on their need, and then based on their interest, and then based on their gap, they can pick that one. And then we can keep on monitoring and evaluating that curriculum, so that we will have the most up-to-date. And then the old issue is should not be on traditional basis or not more a Western, influenced curriculum. We need to have a curriculum that engage with the changing landscape to develop dynamic health economic curriculum, which can be adapted and adopted by potential trainers. So that is the overall aim. And then we established a term of reference. And as you see, we have members from Nigeria, Uganda, Senegal, Ghana, Kenya, Tunisia, and then as well as Rwanda, especially with the policymakers. We do have co-chairs, both from AfHEA, and as we all know, Justice, he was the one who initiated this one. So we do have the co-chairs, and technical consultant was engaged through this process. And the AfHEA focal, the Africa CDC focal, has been working almost the last 7-8 months to make this happen. So we go through all these phases. In May 2024, we established the curriculum, and then we had a clear term of reference, the duties and responsibilities, as well as the inaugural meeting. We had an in-person meeting in June 2024 in Accra for 2 days, and then we reviewed the term of reference, and then we also defined the main thematic areas where we should have to start for this work. Then the final draft was developed in December 2024, jointly with the University of Rwanda, to have the initial comments and inputs on the curriculum. So this work has been evolving through this process, and it's open for scientific community like this one. So any comments we will gather, and then we will push it to the final stage. So in 2025, we are aiming to have this side event, as well as to have a validation. I think validation, I'm sure Johnny may not like the word validation, but at least a final output, and then we will launch the curriculum to be an open source, as I've said it. So I think strategically, the Africa CDC, because I'm from Africa CDC, I need to pitch. so we are aiming to have a finalization, and then we do have also a plan to have a mapping of the health economics curriculum, and health economics capacity. We know AfHEA they did for the academic institution, but we would like to know what is the existing capacity in the ministry, in the National Public Health Institutes. That is a solid baseline information. Then we are going to, as I've said, open source, and then start to have a short courses, because as the Africa CDC, we don't do the academic, what's the academic works, but we'll pick some areas and then we'll focus on some short courses to put it on a digital platform. We are mobilizing, at least we are trying to reach out funders on that, and then aiming to have a monitoring and evaluation system jointly with AfHEA, so that we'll have a live health economic curriculum that fits to the demand of all the AU member states. With this, I think, like as we have been saying, AfHEA has been there, and then we do have also funding support from AfD, from Dr. Agnes and her team, and then thankfully the dedicated health economics curriculum working group members has been there recently. The World Bank is also supporting us on this from Africa CDC, and then Clinton Chai team and Spark team has been with us, and they will be with us in the next step. Thank you so much, and that is a brief background.
Thank you. I hope this plane is ready to carry us on.
Yeah, that was the first team deployed for Ebola outbreak using the military from Africa CDC.
Good. I thought this plane is ready there to carry us on as part of the committee. I will quickly, because of time, 11 o'clock, and I think we're not being hardly, I would say. I would open the floor to maybe if there is any comment so far. I think it's also important before we pretty much go into his presentation. Is there any comments, questions, something to bear in mind? So as we go ahead, we might begin to address them. Yes.
Yeah, just a quick question. So the idea of curriculum.
Can speak up a bit because of the mic. Yeah.
Yeah. Will AfHEA or the developers of this curriculum offer those courses online such that they provide a certificate at the end, or this will solely be to universities to adapt and then see what sort of certificates they offer?
Okay, very good point there. Yes.
Thank you so much. Just want to raise a point about speaking more aligned. There's the transit program. It's community assistance from Southern Africa community. With the University of Europe, University College London, Dublin University. They are also developing a curriculum within 9 countries in Africa. And this work is already ongoing. And I see some of the 9 countries that are also in scientific community. So I think we need to see how we align these two processes. Yeah. Because theirs is also an Africanized community. I also see from those this is
very good point there. Yeah.
Mine is also related on the issue around the language. So Europe also used to offer this. So now it's the resources there.
front. Yeah, oh, yes.
Okay. I think just firstly, I think this is a great initiative because the gap is established. And then secondly, also is looking at that trend, how we improving the curriculum, training institutions, and bringing the policy. I think the aspect of development work, the needs also need to be involved so that it is on the table. What you do when you go and do health economics might be different from what you do in practice as health financing. That's developing how we do health financing. Also, for instance, the conversation we do in health economics, we want to bridge that gap. Of course, while we have the RSFP presenting the policy, it's also to see how else this curriculum will be used. Whatever output, whatever capacities we build, how we use to help decisions, and then the chain of communication continues between those three.
Yeah, good points. Yeah, many of them now. Maybe let's try and address them before we take maybe a second one. But I think it's important we engage rather than presenting. You want to take a stab at them, or
no, you can.
Okay, good.
Yeah,
Okay,
especially on the first.
The first
about
one.
the certificate and
yes,
everything.
let me go with the certificates, and maybe I'll come to you as well. The issue of certification, AfHEA doesn't have any local standing to give certificates beyond with that is of we can give participation certificate, okay? You can come and do something online and give certification of participation, but I don't know to what extent that can help you in your career. What we want to do is this becomes available to universities and training institutions who can offer them either through their accredited system to provide the service and give certificates according to how the institution is structured. So we don't give that kind of certificate. But what we do is we have capacity building workshops that AfHEA hosts. So we could have capacity building workshops or a workshop on expenditure tracking, for example. And that's usually open. People come and participate, or a workshop on scientific writing, for example, or disseminating research, blah, blah, blah. We do that from time to time. And if you want the certificate of participation, you can always avail that. I don't know from Africa CDC,
yes,
you can speak to it?
Yeah. So I think so basically there are ongoing fellowship programs on the epidemic service and related to that one. And then even short courses. So there is a certification process that will be provided, but here we will make it open source, as we said, and then, okay, Africa CDC will take its portion, you see, and then, AfHEA will take its own, so the university. So that's how it works, but depending on the need, and then our mandate, we'll pick some short courses and we provide certification for that. We do have a health workforce department, which we are going to work closely so that we are going to learn how they have been doing on that space, and then we will contribute. Yeah. That's from there.
I'm glad we have Africa CDC and we can talk more about it. Yeah, you have the point?
I have a follow-up question.
To this? Before,
yes,
okay.
and also a suggestion. There is a way that, because we believe that this curriculum responds to the needs as we work for government, and the idea is how can we expose those who can take that course to do platforms. So I think maybe Africa CDC and other organizations who can step ahead, and we have our professors here who can brought that idea, pitch to the universities and say, okay, we have a curriculum that responds. If, for example, there is a master's student who is going to work on the health economics unit, which mostly traditional and never responded to what, because here, based on what we discussed, it's case studies, and why the case study respond to the real scenario, even though it is quite virtual kind of. So I think we can teach them through the digital platform, and their university can take exam. So just like a course, then they can take like a special course, then they can do example to be academic, because we want to keep the value. If we took of course, we get a total reach, which is very high, which shows that the feedback we can get from the students will help us to keep updating our curriculum. So I think that's what maybe you can do. Thank you.
Yeah, good points. Good points. Yeah. Go ahead.
Okay, thank you. Something just crossed my mind. 2014, 2015, AfHEA, so those early days of UAC, so AfHEA organized some series of trainings, both for Anglophone and Francophone, where we trained both practitioners, policymakers, researchers, academicians on the fundamentals of UAC, how to design a UAC program, how to implement UAC programs, and also how to monitor and track UAC interventions in the various countries. And I think that was very helpful. So possibly we may need to look back at that model, because it helped to train a large number of people. WAHO, West African Health Organization, also adapted that to do more deep dive training for Anglophone and Francophone West African countries. I remember that course, we did it in Kenya. So we had a lot of folks, we did it in Nairobi for 2 weeks. We ran like a residential program then for 2 weeks. And it was very rich and deep. So that was long before we started discussing this. And that curriculum was developed with different experts from AfHEA and also had government participants. So I think we may think of leveraging that model. Then another thing that just, while you were speaking about students, so there was this program that the Nigerian malaria control program, that they had an implementation research agenda. And what they tried to do was, what are those key questions, both operational implementation related question policy, and then students who are running MPH programs picked their thesis from all those research questions. So it may be something that we can do in addition to the curriculum, where we may think of a research agenda around the health economics and policy as it relates to our various countries, the questions that policymakers may have in mind. And then the schools that are offering health economics, policy and financing, the students, both master's level and PhD levels, can have like a bouquet of research questions they can pick from for their thesis. That may be something else we can consider.
Yeah, very good. I'll come. Okay, is it on this?
Yeah. There was a question on.
Yeah, because I'm going to that one. Yeah. If it's not on this, then let me go on that. Then we'll take it. That harmonization, it's a very, very important question there. That fragmentation. A lot of, things happening everywhere. Sometimes we are aware, sometimes we are not aware. That's why it's good to have us all here. Things that you are aware that we're not aware, you bring it on board. I totally agree that we need to harmonize. Now, the issue is, how do we proceed? How do we get them on board so that we would have a harmonized, rather than we have some things that conflict? How? I don't want to impose any way to proceed. You want to talk to that, or before I get someone?
Not yet.
Okay, good. Yeah.
Yeah, so I'm part of that big project called AfHEA, Economics Policy Impact. And the Anna saying, I think she's also part of the network. So there's universities, but it has EXA, the East African community. So it's not difficult to get communicate. As you know, any delays and all this curriculum that we have, so that because now we are starting to look at curriculums from different countries, see what are the gaps so that we can harmonize. So maybe we give ourselves some space, and then we initiate the session, and then we share what we have done, and then see how we can work together and get much together.
That's very good. Yeah, to have us sitting in our spaces to also cross, learn, give feedback. Yeah, that's a good one. Yeah.
We will have one convening also to incorporate all the inputs. So during that time, also we can reach out, or we can bring them on board. I think, yeah.
Yeah, you get it. It gets great. Yes.
I think we're not delayed with the launch. So we'll go ahead and see how it goes. Maybe after 1 or 2 years, we want to review. Okay, we can now call for submissions. That's when because apart from these two things, these two groups, AfHEA and the other one, there are others. The universities are running their program on their own and all that. So I think the more the merrier. And let's continue building capacity in health economics in various ways. But at a point, we need to begin to narrow it down.
Yeah, let me come again to your point. You talked about Hero having run health economics program previously, and even within the WITS University, you have 2 departments. The Department of Economics running health economics, then you have the School of Public Health running health economics program. So you have this kind of, and somehow we kind of sit on the different spaces. For example, I externally examined for both the WITS University School of Economics as well as the public health. So there's some kind of differences in how they are taught in different. I serve as examiner for both somehow. It's strange word. And so there are what we did, which Chai did talk about. Matiko, we've done some kind of scoping review for the continent, looking at the kind of training that different institutions run, and we try to curate them. Perhaps that is one of the ways that we can know what's happening. And the fact that we have representatives on the working group from different regions, we're able to also get insights in the different regions, what they do. The training of health economics at the University of Cape Town is also one that is relevant to mention. And the beauty of it was that I was wearing a hat as a former director of the health economics unit at the University of Cape Town. So that also allowed us to bring in the training that we used to provide at the Department of Public Health at the University of Cape Town. And there were many others that people on board brought as well. We had a very important input from the University of Nigeria as well, my alma mater. Having policymakers on board allowed us to explore aspects that are traditionally not considered in training. We know we may not have done so much, and that's why we're here to ask people to make inputs. I'll be happy to take more. I know there's a comment. It's not really. It's more. I would take this comment intervention as a comment, except if there's something else we want to respond to that I missed. I'm trying to talk of my head. Is there anything that we missed?
So it's about alignment.
Yes, alignment and
yeah. I think
so. The floor is yours, Dr. Yao, who has graciously served as the secretary of the working group to present. Thank you.
So thank you, everyone, and you're welcome to the presentation. It's going to be in 4 forms. So the first one will be the presentation at the master's level. We have done this in different levels. So I'm going to start with what we have at the master's level. And for the purpose of time, we will be much interested in the structure and the course content. That is where the attention will be pretty much. So we propose that this should be 18 calendar months for those who will be doing this at a regular level. And for those that will be taking this in part-time, it should range between 24 and 36 months. That is at a part-time level. And over here, we try to come out with some core competencies. So these core competencies form the core of this master level program. So among them include Introduction to Health Economics, Principles of Epidemiology, Biostatistics, Economic Evaluation for Health, Health Financing, Equity Analysis, Economics of the Health Systems, Health Policy and Planning, and then the final one will be the research method. Okay, so this is going to be the structure. So it's been divided into 2 or 3 semesters because we are looking at 18 months calendar period. So in the first semester, the core courses or models we have proposed includes Introduction to Health Economics, Principles of Epidemiology, so economics of the health system, health policy and planning. So this will be the core courses for the first semester. And we know that a complete program in this nature will require an elective subject. But for the elective subject, we have left it to the institutions to decide which elective to opt for. So there will be 2 electives, and that will be what the institution decides to look at. In the second semester, we'll be looking at economic evaluation for health, health financing, equity analysis, and research methods. And again, there will be 2 electives for the running institutions. And the third semester will be devoted to the project work or thesis, either thesis, dissertation. Okay. So now we move on to, so we're going to pick them, the core courses by core courses for the respective semesters. So for Introduction to Health Economics, these are the objectives we anticipate. So by the end of the course or model, we expect that participants for the program will understand the basic principles of economics and health economics. They will also be able to analyze the demand and supply and their determinants in both general and then healthcare markets. They will also be able to apply the economic concepts such as utility, elasticity, productivity functions to healthcare. They will also be able to evaluate the market structures and their implications for healthcare. Assess the causes and consequences of market failure in healthcare, and then we'll explore the role of government interventions and policies in healthcare markets. So the last objective will be to understand the link that exists between macroeconomics and health and how these have impact on economic policies in the healthcare market. So these are the course or model objective for the. Now these are the contents. What we intend to look at within to achieve the outline content. Within this we have SATs, but we didn't want to make it. So maybe as and when the questions come, we will then try and dwell into this. But we have considered Introduction to Economics, where we look at basic economic principles, basic economic problems, and everything that we need to know about economics will be under the Introduction to Economics. And then we have Introduction to Health Economic Concepts. From there, we look at demand and supply. So in each of these, we look at how it is related to the health, how it is related to healthcare. We also look at production functions, market structures, and then the last will be the introduction to macroeconomics and how they are related to health markets or the healthcare sector. So the second core course or model will be the principles of epidemiology. And here we anticipate that by the end of the course, participants will understand the historical development of epidemiology. They will be able to calculate and interpret the measures of disease incidence and prevalence. They will also be able to distinguish between causation and association. Again, they will design and critically evaluate epidemiological studies. They will also be able to identify and control for confounding and biases, assess the validity and reliability of screening tests, conduct disease surveillances and outbreak investigations, and then apply epidemiological methods to the study of communicable and non-communicable diseases. So realize that in the last parts of the objective, we devote that to the practical aspects where we try to come in. We try to introduce you to the theoretical aspect and then bring in the practical aspects. So what are the courses, the contents for this course or model? So here we're going to look at the introduction to epidemiology, the measurements that are involved in epidemiology, incidents and preventions, causations and associations. We look at measures of association and the various study designs that we have under epidemiology, biases and confoundings that are associated with this. Screening test validity and reliability methods will also be discussed here. We also look at disease surveillances, outbreak investigation. We look at communicable and non-communicable diseases. So this will be the key things that we're going to look at when we're looking at the principles of epidemiology. The third one is biostatistics. So these we are saying should be core. Every student or learner that happens to be within this field, taking masters should have this as a core. And we expect that by the course of the model, by the end of the model or course, participants will understand the basics of statistics and its applications in biological research. They will also be able to differentiate between populations and samples, define and organize data for analysis, present data effectively using various graphical and tabular methods, calculate and interpret univariate descriptive statistics, and they will also be able to apply the significance tests and understand their principles or the principles that surround these tests. Again, we expect that by the end of the course, participants will be able to compare means across different groups using parametric and non-parametric tests, analyze the relationship between variables using correlation or regression estimation techniques. And then the last one, we will be looking at the research softwares that is going to facilitate this also. This will be a hand-on exercise for participants. Now for the course content or models, we'll be looking at introduction to statistics very briefly, organizing and displaying data, univariate descriptive statistics. We'll be looking at normal distribution and probability, significance tests for a single mean, and significance tests for two or more means. We look at the key principles of statistical inferences, parametric and non-parametric tests, differences among group means, correlation and regression. We will also look at factor analysis. And then the last option will be the use of statistical software, which may not be limited to what we have here. It may go beyond that. So we have theta, R, and cells. So next will be economics of the health system. Economics of the health system. So what do we expect to achieve after taking this course? So we expect that by the end of this course or model, as may be termed, participants will be able to define health systems and their components, as well as their functions. They will also be able to analyze the theoretical health system typologies, including African health systems. We will also be able to trace the evaluation of universal health coverage and global declarations. Explain the WHO's 6 building blocks of health systems and their interrelationship. Participants will also understand the impact of social determinants of health on health outcomes and disparities. They will also be able to compare and apply different health system frameworks to assess performance within the health system. They will also be able to analyze economic implication of corruption and political economy within the health system. Again, they will be able to conceptualize health system as a complex adaptive systems and apply systems thinking. Identify and evaluate global health challenges, including the impact of healthcare terminology and innovation. And then the last objective will be to assess the economic impact of emerging health challenges and healthcare crisis. So this is what this course or model will seek to achieve. What are the course contents for this model or course? So in here, we'll be looking at introduction to health systems, UHC and global declaration with case studies. We also look at the WHO building blocks of health systems. We look at social determinants of health, health system frameworks, economics of corruptions, complex adaptive health systems, and then the last section will be devoted to emerging issues that we have in the health system, or we have in health. So the next course looks at economic health planning and policy. Health planning and policy. So here is the expectation that after completing this course or model, participants will be able to articulate the fundamental concepts, principles, and importance of health policy and planning in various contexts. And then they will try to explain how these policies are aligned or linked with the national health goals and international commitments like the SDG goals. Again, participants will be able to apply analytical frameworks to assess health system performance, with emphasis being laid on equity, efficiency, and effectiveness. Participants will also be able to evaluate the role and effectiveness of PPPs, the public-private partnership, in enhancing health system service delivery and financing. Participants will also be equipped with health planning and management knowledge, focusing on designing and implementing effective health policies and systems. And then they will explore emerging global health issues such as AMR, climate change, and pandemic, and their implications for the health system. So this will be the content for this course. So we'll be looking at health policy and management, health policy evaluation, budgeting and planning, donor transition and planning, project management, PPP, and One Health, which houses the last aspect, AMR, and then climate change. Everything will be devoted or treated under health policy and training. From there, we look at economic evaluation for health. And we expect that after going through this course, participants will demonstrate an in-depth understanding of economic evaluation techniques in health and the applications in different health care settings. They will also be able to identify, measure, and value costs, as well as distinguish cost types and apply costing methods to cost national strategic plans and strategies. They will also have the capacity to conduct and interpret cost effectiveness analysis, cost benefit analysis, cost utility, as well as extended cost effectiveness analysis using real or hypothetical data. They will also appreciate or appraise the published economic evaluation papers, assessing their validity and the methods that were used in such paper or for the analysis. Again, they will be able to apply economic evaluation techniques to support evidence-based decision-making in healthcare, and also inform policy choices related to resource allocation and intervention prioritization. So lastly, participants will gain practical experience with tools and softwares that are commonly used when it comes to economic evaluation. Now the content. So the first part, we'll be looking at introduction to economic evaluation in health. We'll look at costing in health economics, how measuring in health outcomes are done, economic impact analysis, such as cost of illness study, budget impact analysis, cost effectiveness analysis, cost utility analysis, cost benefit analysis, and then models in health economic evaluations. The last one will take how we use the softwares we have to do economic evaluation. The next core model we identified was health financing. And we anticipate that by participants completing this course, they will be able to understand the mechanism and strategies for mobilizing financial resources for the health sector. They will also have or be able to evaluate different approaches that are used when it comes to pooling resources to enhance efficiency and utility and equity in health financing. They will also be able to identify and analyze alternative financing mechanisms for health. And this will include health insurance, user fee, PPPs, and others. They will also be able to understand the concept of strategic purchasing and its significance in improving health system performance, as well as develop strategies for purchasing health services that promote equity, quality, and efficiency. They will also be able to utilize resource tracking and mapping tools to monitor inflows or financial inflows within the health sector. So within the model, we'll be looking at introduction to health financing, resource mobilization and pooling, strategic purchasing for health, public financial management, resource tracking and mapping. So within this, we have subheadings. I know this will come up in the discussion, so you will get there. The next core item we identified was equity analysis. And we anticipate that after going through this course or model, participants will be able to define and differentiate between equity and inequity in the context of health. They will also be able to understand and explain the principles and concept of equity, including the distinction between equity and equality. They will be able to analyze and critique the theoretical and philosophical underpinnings of equity in health and healthcare. They will also be able to measure and interpret equity using various indices and statistical methods, which includes the Gini index, the concentration index, range, and then variance. They will also be able to evaluate the impact of vertical and horizontal equity in health outcomes and health system, as well as developing and applying asset indices for measuring socioeconomic status in health equity research. They will also be able to assess and propose strategies for improving health equity within different health systems and policies. So this will be the course contents for this core model. So we'll be looking at introduction to equity in health, principles and concepts of equity, the theoretical and philosophical underpinnings, measurement of equity, vertical and horizontal equity. Here we'll be looking at several definitions with examples, equity and health outcomes, equity and health systems, asset indices and socioeconomic status. And then the last section will be the practical applications and case study discussions. The last core model we identified was research methods. And we believe that you cannot come out as a master's graduate without having to take this course, because it will be very key when it comes to your project work or dissertation. So we expect that taking this course, students or learners will be able to design and conduct research studies in health economics by taking into account appropriate methodologies to investigate key health issues. Again, they will be able to analyze and interpret health economics research, integrating and synthesizing findings for decision-making in health. And not only that, they will also be able to clearly and effectively communicate complex health economics concepts and research results to a wider range of audience, which includes policymakers, stakeholders, and then the general public. So the content for this course will include health economics research, research design in health economics, data collection and management, quantitative methods, qualitative methods, and the last aspect will be knowledge translation for policy. Now, these are the proposed mode of delivery for this course. So it could take the form of lecture where we could have in-person meetings, virtual meetings, hybrid, and then which basically takes into account face-to-face and then online, or in-person and online. And then there will be some case studies which we will apply. And then the mode of assessment will include, but not limited to this, quizzes and examination, just as we have in traditional systems, report and presentations, group activities and projects. And we have the last one to be experiential learning, where you'll be given a task to do in that regards. So thank you. And Joe.
So, when you have eminent people in your midst, you can get distracted. So it's part of it. So welcome, Professor Obi. Very interesting overview of the content of the master's curriculum, okay? And you will notice, which is interesting, is that you can move things from here and there, but what we want to do is that we have the content ready. For example, a content might move from equity analysis and it might move to health financing. Okay, but most importantly, that content has to be covered. You might also move something from health financing and, oh, well, this is health financing, but I think it can move into equity, for example. So you could move things around. Note also that these are indicative. It's not like if you want to run a master's in health economics, AfHEA and Africa CDC and whoever have given us the Bible, and all we need to do is flip page to page and we stick to it like dogma. No, this is something that is adaptable. The last bit he was talking about regarding the mode of delivery is one that I really want to hammer on. You notice he talked about case studies. Case studies would pretty much be splattered into all the sections, all the modules. So we're not waiting to the end to say, okay, now it's case study. Now let's do health economics case study. Somewhere it's going to be a killer. And that's where we differ, I would argue, from traditional health economics training programs, even being offered on the continent. Many of them are very theoretical. A little bit into practice, but far off reality. Far off reality. The problem that many of them face is striking a balance between we train people who might continue to become academics, who might go into industry, who might go into policy, but they don't really focus much on policy. Focus much more on the technical aspect for people who end up becoming teachers, like me, more teachers. Okay. Another big challenge we have is the fact that some of them may be heavily economics. Maybe heavily economics, okay, in the sense that you lose the health system or application within the health sector is thin. And some would again lump themselves into a more on epidemiology and less on the economics. So how to strike the balance between health, between economics and public health is critical. And to a large extent, it will depend on where the program is being offered within your universities. If the program is offered in an economics department, it has a slightly economics tilt. If the program is offered within schools of public health or community health or community sciences or health sciences, it is offered again the way tilted towards public health than economics. So there is a need to strike a balance, and that's what we put here as essential things wherever they are offered. If they are offered in economics, it doesn't stop you from fulfilling the demands of the department. The department requires you to go to macroeconomics, microeconomics, quantitative or mathematical economics, econometrics, or any other thing that is the demand of you in that department, because you need to fulfill the demands of the department. Over and above that, these things must be covered for you to come out to call yourself a health economist or someone who's gone through a master's program in health economics. So what we'll do is, I know there is time for us to have questions at the end, but usually it's good when things are fresh in our minds to ask questions. On the chat, I usually say chat box. I think I should have corrected that, and I was corrected here. The question and answer box online, for those of you who are online, please drop your questions there. We'll pick them up and I'll go over them and we answer them. But for you who are here, feel free to ask your questions and we will address them if possible. Oh my goodness, this is, I'm inundated here. Again, I like starting with women. Let me start from that side. Yes.
Thank you so much. Because we are looking at training of economics in Africa, and when I started work, we do trade children rates because it's standardized. But you also mentioned that this. So, are we going to have the minimum that every institution should have, and another optional to be able to? Then the other small one is we should look at the small grant to the universities kickstart this training. And this maybe can be organized at Africa CDC. Because I mean, we have the economists, but starting the training program, maybe we can say it's not grant, but few universities.
A lot of questions there, but maybe I don't like answering up every question because I work with a team. Did you pick the questions you want to go with it? I don't want to start answering questions now.
I did not.
You didn't pick her questions? Okay, I'll try and recap her comments. She says that we can, let me start from the last, that we can, more like pilot. What she's trying to talk about, more like pilot. That can we get a small grant because it's very expensive to do training? Get a grant from somewhere. Maybe she's going to give us. And then get a university. It might be Wits University, for example, or University of Nigeria, or wherever, to start piloting or run this to see what it comes out with. Then the other one she talked about, the first comment was about that is not the Bible. Yeah, that's not the Bible. Okay, good.
What should be the minimum?
Yes.
At every health economics program.
Correct. Yeah, because it's not a Bible, and every institution should have like what are the bare minimum for you to say, I have graduated, I'm a health economist, and I expect you to have these either core competencies, or you should have had these modules done. I think it's more around core competencies. Yeah. Do you want to answer that? There are lots of questions. I don't know how we're going to deal with it now.
So we collect some questions and then
we answer.
Yeah,
okay, good.
Yeah.
Next again, we're going to go.
I just have two comments. The first one was on the fact that we left the electives, the institutions. Believe me, there are some institutions who have hard time funding electives. So why don't you provide just an list of some electives that are relevant for our region? The second point is on the strategic purchasing. It's something I've worked on. Really for example, I think we need to talk about provider payment records. It includes strategic purchasing, but also behavioral economy, those things. I think we better have the students be equipped to help our government about this. And the last thing is, there are a lot of program things that are really relevant to health economics. Maybe we should encourage institutions to have seminars on topics that are very important, so that, for example, writing a policy and all those things, just one or 2 days seminars, but if it is going to be a curriculum, I think the universities will know how to implement it. Thank you.
Good. She had 3 things there. If you pick them up, last 2. One is about the fact that strategic purchasing can be subsumed, in her words, under purchasing payment mechanisms. And then one around open electives, that can we kind of tighten the electives to make sure, well, we don't just go do things anyhow. They want to do things. And lastly, she talked about having seminars. Let me continue again from this side, and I'm exhausted, and I'm yeah.
The one that's on the top side, I know it's part of the question, but I think any students want to have something to do with policy.
Okay, she's saying. Okay, she's saying she doesn't see policy coming out there. Although I remember you have health policy and planning. Perhaps it needs to be done something. We're talking about how that's going to happen. Now I'm on this section. Any questions here? Okay, you have first. Okay, no, that is a different section.
Oh, okay.
Yeah.
Okay, so thanks. So under economic evaluation, so there was no mention of AfHEA, health technology assessment. So would it be included in the introduction, how to institutionalize that? Because I know it's not really strong in our continent. So maybe it's something we could take into consideration. And within that same framework, because we know what we faced during Ebola, all of that. So vaccine pharmacoeconomics is important. So vaccine economics is also something that we should, because we procure, so we should, like whoever that we are training in health economics and finance should really understand a lot more around vaccine economics, pharmacoeconomics. This is just what a suggestion. I think is especially for our continent. We know what we faced a few years ago. So we are trying to see how do we start becoming more independent in producing the essential medicines and vaccines we need. So understanding that even when we are doing the healthcare markets, maybe it's important for people to understand the intricacies of such vaccine, because it's really, I know Gavi transition, for countries that are under Gavi transition, you are required to provide some funding for co-financing, and also there's a lot of complexities around that. So it will be important for our people to understand that. Maybe a bit of the results-based financing, but also whether it's under financing, the budget, the one about budget impact assessment, and also with respect to investment. So resource mobilization, the state where we are in Africa, with the transition in terms of foreign aid, how are we going to mobilize resources to fund our health sector? Is it something critical? So we need to understand there are things around impact investment, private sector. During COVID, the private sector mobilized to fund at least Nigeria and several other countries. So beyond just PPP that is narrowed to just maybe hospitals using PPP, how do we mobilize? So we have a mixed health system in Africa. So both public and private are intertwined. And it's important that we see it from that perspective. So seeing how social bonds, different types of investment. So seeing investments within the health sector, how best can we attract investment into the health sector? How do we do business cases for specific conditions? And also, I think these are important for us to consider in the curriculum. Thank you.
Yeah, very, very important points there. Next day, yeah. Now, there's going to be a problem here for many, challenge for many people. I don't know how we can do this. This thing doesn't move beyond this point.
Come forward a bit.
If you don't mind, can you come close to the microphone? Thanks. Sorry. So sorry.
C'est quand même pas long. Hein? Je voulais savoir juste quelle est la place de la pratique dans le paquet qui est proposé. Parce qu'une chose est de donner les connaissances, mais l'autre c'est d'avoir des personnes qui sont formées, qui sont capables d'utiliser les connaissances. Est-ce que cette quantification de la place de la pratique a été faite pour qu'en formant au fur et à mesure, qu'on puisse aider à faire une intégration professionnelle, qu'on puisse aider à faire l'intégration professionnelle?
Good. I think he's pretty much raising points that are comments, that the goal is to be able to have people who are trained and equipped within countries to be able to provide support, especially the Ministry of Health or Finance as well. People really don't mention that. And also insurance agencies and some other food and drug regulatory agencies or authorities within countries. It's pretty much generating a pool of health economists. If I get maybe at least
emphasizing the
practical aspect as well. That's not just getting them out, but they have practical skills. Now let me talk about experience from my own setting. I'm coming line by line. You'll get it. I'll get it. Experience from my own setting is that we find that even the teachers don't have the requisite skills to deliver. We can list 1,001 things here. I don't have the requisite skills to deliver all of them.
Absolutely.
So you have a university where there could be 10 staff members or 20 with their own specialties that you miss some, and it's genuine. I mean, you can't be everywhere. So what universities end up doing is they teach based on the expertise they have, and the expertise they don't have, they teach theoretically. You know what I mean? So, for example, if I'm called upon to teach something on pharmacoeconomics, because I'm not vast in pharmacoeconomics, I can teach, but in a theoretical sense, and that doesn't give students the practical things they want. So maybe we need to keep that in mind, how we deal with it. I'm talking from experience here. Keep that in mind. Yes.
I think that this is related to what you are sharing now. Like of these 9 modules, will they be available as short courses so that if they're seasoned health economists who, for example, don't know much about financing, they can go and do those?
Okay. The reason why I reiterate the questions is especially for the French speaker, so that I summarize it for you to have the questions. Now, she's saying that the 9 courses, awards, that are they going to be developed into shorter courses or short courses and made available to people, basically? Asking a question. I'm part of it, but I'm still asking. Any from your side?
So, thank you, John. Thank you very much. Mine, I feel like after it's been long, I feel like going back to school. Okay, so I was looking at the biostatistics
module, of course.
I saw the
test of association was limited to correlation and differentiation. So from experience, some students who want to probably do their project or something, and look at their data, it doesn't fit a correlation. If left open, there are t-tests and other that actually can be incorporated to that. Secondly, is on building blocks side. I also saw that it's related to some of these countries actually, especially Nigeria, where I come from. I know we have our own country-specific building blocks, so we can actually add it as an additional thing to grow. Thank you.
Okay, I will summarize again. The first is about the tests of association, that we can broaden it beyond the t-test or something of that nature. We look at parametric as well as non-parametric estimations, and you may. Sure. Okay. That's okay. Yes. I'm just trying to reiterate this question. I'm not saying whether they exist or not. That's the different. And then the second part is, you said that there was emphasis on the WHO building blocks, that in different countries might be different frameworks that different countries use. You talked about Nigeria. So how do you harmonize that? Though I saw in your presentation somewhere you talked about other frameworks, which my understanding is perhaps you should have subsumed the WHO framework into it, and rather than mention only the WHO framework, but just for you to keep it. Line by line, you good? Good.
Yeah. Okay. All right. Thank you, John, and thank you, presenter. So mine is to do with HTA. Whether the committee found it relevant in Africa, or is it something that we can forget about for now? Thanks.
Okay, his question is HTA relevant in Africa, or should we just teach it and do something else? Good. Good.
Yeah. First, I would like to thank both people who contribute to this level of developing the curriculum. I have many questions because they're very good work, but I will limit on 3 questions. My first question is, I don't find any relation between the target audience and the entry requirement. There is a big problem here. The second point is about, I will explain why there is this target. The second why the entry requirement, there is entry requirement, and this is master is devoted to 55, I think, countries in Africa, not for 3 or 5 countries. They have different classification, different diploma, different. For me, since a long time, I'm more than 25 years at university, jumping from different universities. Really, the first time I see a second class lower division. I don't know what it is. This is diploma, graduate. This is for some specific country. We need to be standardized this requirement. The second requirement is to hold postgraduate diploma with credit in health. Believe me, we will not have this one. All people that have health economics postgraduate, they will need to have. They will to go through doctorate, many things. They will not find this on health management, health policy. They will not do again what is already done. So I think that the third one is most suitable. And we will find that the audience, it will be from this course of professionals who have already from the first one, the diploma in economics, in public health. I will ask, if you ask question on all the health economics, we are here. We are coming in the field of the health economics. All of us, I think most of us, I'm one of them by chance. I never I study economics. Under the level of master, and by the end of the master, I'm recruited at the Institute of Health. So there is health economics. By chance, but I never study health economics. And if you give the opportunity to new students to choose what they want to study at master level, health economics will be the last one. They want to go to banking, finance, yeah. So this is, I think that you have to make the link between the target audience and the requirement. My third question, I will stop, is about the introduction of health economics. This module is the most important one. This who will let people to like this field or do not like this field, dislike this field. And many of the population of the target audience who will come, they will become because they are sponsorized, they are motivated by their job or something. I think that this introduction to health economics need an introduction to health economics. Because if I see the sub-module, first, the sub-module are not linked to the objective. And we start from the first to start with demand and supply. This is a very huge, very complicated for people. Whatever, if they have already a master diploma, here we need, like we say, on the objective, we need to explain what is the role of the government, what is the market, why there is a specific need for health economics, why the health economics was created in this world. They start, this is I think the last sub-economics study that what was created in the this work. So this is what we need to introduction, and the introduction should explain what we will see for the other modules and why we need to know some aspects of epidemiology, why we need biostatistics, why we need to implicate health policy. This is what my third point.
Thank you. Great. Very, very good points there. I'm sure just close the mic enough for those who needed translation. But if you didn't pick that, I'm happy to. If you speak here, I don't want to cap it. Yeah, we're moving on to the next.
Thank you very much. And I want to congratulate the authors of they are really experts. And you can see from the conversation, you agree with me that health economics is like a cancer. Spreading and grabbing everything. Yeah, but having said that, I think we can go further than this to be able to unpack some of these things. There are two books I usually like. One is Something Medicine or Something for Dummies. So if we can have health economics for dummies, or health economics medicine, it will be easier for people, especially the policy makers, that I think require capacity to comprehend. And because there is so much about health economics, we should be careful what we pack into that space. Otherwise, you get confused. But the good thing I like about this, you can pick a block and expand on that, and people become competent in that. If it's equity analysis, economic analysis, and all that, it is the health technology assessment that comes. So that's the beauty of this. So that we don't go home thinking that before you become a health economist, you must have gone through all this. It's even frightening. That's the end of it. Thank you very much.
Okay, very good point. I think it was loud enough. Loud enough. Yes.
Thank you. Thank you. Congratulations to the beautiful work. Also, what the participants mentioned. I just want to say that as we're doing this two-to-one confirmation, I think it's important we ask the end users from government, what competencies do you want in your health financing health officers? Development partners, what competencies do you need? So that as we are putting this, we are now developing archetypes. And for universities, this would be a good marketing strategy. Like developing content, variant of this that are fit for those that want to take health economics as academicians to do all the research and what you do. And now go to town with all the crazy stuff, all that. And develop some content that will give easy and hard, both easy to use hard skills for those that will just go into development work, chasing the big problems, follow up, provide still some content. And there are variants of that government people need to understand, assimilate whatever you are giving them, so that will help to unpack this volume that we had.
And we can decide to get all the cozy names to give them. It's marketing strategy for universities. And that will help to make sure that we now have sizable bits of this. Because the second thing is the duration. That is one thing that will put people off on this. Most of the guys that go in for masters in health economics, they want a quick fix in their career. They're saying 18 months full time, that's not palatable. They're saying then 36 months part time. That's definitely not, it will not make economic sense to people that would come in to do this. Because for most people that will come, they're there for the certificate, not for most of the information. So I think while we're doing this missions as economists, but also think of it from the end users, what will make most sense to them. And of course, you mentioned issues of those facilitators, because I had it there. And what competencies do we need in people that will teach this? I did health economics, and from the first module, I know that people teaching me, I just vegetated because I feel there's nothing more valuable than in our countries. High population, limited resources. That's classical health economics. So you should be proud to teach people how to deliver health within context of limited physical resources. So that should be a driver to say that, okay, we are adding to value to the country. But they know people are just there for the certificate. Just come read the notes and move on. They themselves don't understand. I think also, perhaps in terms of competencies, I think it's important to hear other partners in this can we form partnerships that will link some of the academics, some of the institutions to have, even if it's a part-time role, to take on some of these conversations, some of these topics, so that we are now blending. Because the truth is, the passion with which you teach, John, the energy with which you teach, will make people to fall in love with what they are being taught. So if you get people that are passionate about it, taking some part-time roles to do this, it helps to spice up what institutions are already doing. That can be the beginning of using competencies. And so I think these are my.
Perfect. I think that's very loud enough. One thing I wanted to highlight is the issue around duration. What I would say fortunately or say unfortunately is a challenge is that some universities have rigidities. That once the program starts, you cannot carve for yourself a different duration. So whilst a program, a university can be free or in its own statutes can offer that master's program 9 months. In another university, 9 months is no for them. They will tell you for the master's, it has to be X. That's okay. You can't get around that. So do we therefore be prescriptive in terms of saying, hey, this has to be run in 18 months or, and then for that university, they don't do 18 months. They're like, this is crap. We only do masters in 9 months or in a year, and anything must have to fit into a year. Or do we say that what we have here is for them to adapt and fit within their own system, rather than saying 6 months for whatever, or 9 months, whatever. Let's be silent on duration, but be suggestive, but not prescriptive. Something of just suggestive. I think that might help.
Thank you. I think I can start saying that at least we have something that we are saying. We know where we can start, we know where we can start. That's because they did a amazing job. And why I say that, what now is remaining, what will be our competitive advantage, our curriculum, based on our classical. The reason is, I can say, one is that there is a bond. in between policymakers, economists, people within the public health. So which means that that's uniqueness that I think we should be proud of and see how we can tackle with it. However, there is a still gap to improve as someone who did economics. Now I see. But some bodies are overlapping with each other, which can create a confusion if someone who is going. For example, I can give an example. You cannot tell me that you're health finance model without having a clear concept of public sector economics. Because the person you are telling to analyze resource mobilization, to do resource mobilization, need to first understand taxation, need to understand debt sustainability. We need to understand investment process. Because I'm saying because I didn't understand. That's why I understand that. And another thing that maybe we should improve, I can say when I started taking the health economic process, economy or something. Not the health, it's economic for health. Which means that we have grown big concept in economics to make the beauty of health. So, which means that, but also currently, of course, we have seen that health is not a standalone. It's a prospective sector that we need touching points in areas. For example, we need to see what is happening in agriculture. Now we are having a climate. So I think maybe the main job is to see how we can make sure we weight fundamentals and link the custom, and also we link with the health areas, matching areas, but also let's think the future. Because right now we have experienced the shortage of investment, but there is a lot of ideas that we get here that can make that that competitive advantage. We feel that if Africa CBC supported the AfHEA supported curriculum is not the future, not the we are not like we are not connecting dots. We are bringing something that can take 10 years, 20 years to see that this is the future of Africa. So that even rather than relying on York University curriculum, we have to see our own curriculum that is on the needs of our population.
Good, very good points there. I think more around overlap, I have to make sure that we streamline things and maybe look at economics broadly. So not just public economics, you might also want to look at some other core theoretical aspects of economics and how it applies to. And that's where that issue around introduction to economics or health economics is important. And the key concepts of economics that are applicable in health economics have to be taught. Very good point. Okay, yeah.
Thank you very much for the
speak up a little bit so that people can hear us. Yes.
So I would like to clarify some issues. I've seen a lot of health economic programs now considering more of data analytics. But I think that in as much as health economics, we are not supposed to learn a lot of things. There are 4 areas, a lot of things, as everybody made mention that you can learn everything. All competencies are things that you need to. I'm certainly using myself as an example. I was supposed to do some inequality analysis, and I was struggling. So I think that the master's level should students be exposed to some bit of data analytics. I don't know whether the biostatistics is going to make up for this. So that is modeling and those kind of things. You have an idea of it. So that in the future, if you want to build that, it becomes easier.
Very good points. I think the points he's raising are critical ones around analytics. So you see, different people are coming with their own needs. The policy aspect is coming out, analytics is coming out, theoretical issues coming out. I mean, you could see the different bits and pieces coming together. And if I remember from your presentation, Yao, you have areas around the modeling in economic evaluation. We also have inequality subsumed in equity analysis. And so there might be spotted into different modules, but maybe they need to be brought out, I don't know, to be able to satisfy his needs. Anyone from there? Yes, please, Sinead.
Clarification. The practical is just theoretical section on the one. How are the emerging topics including on this curriculum, for example, digital economy, climate economy, how can we integrate with this curriculum? The other, what is the plan to evaluate the economic evaluation, like digital tool in the software for economic evaluation?
Great, thanks. I think she raised 3 points. The last one was about software for economic evaluation. I know you just mentioned that in passing. I remember seeing that as part of that. And then one is whether we're going practical versus practice or something of that nature. Then the third one was around emerging issues. I know you did talk about emerging issues, but I can't remember where it fell, but it came up somewhere. So how do we incorporate issues that might emerge that we don't even know now? We leave it open to something that might emerge tomorrow. It might be zoonotic diseases or something that health economists need to be aware of. And how would we put it? She mentioned climate change, and there's one climate change and adaptation. Yes, the last section.
Yes, so thank you very much. So if I don't know so when we think of so if you have that's not when we are reposing, you're more interested in but it will not you must have your advanced scope. You must have to know the so there's a background which may not have been provided in the statistics. So we have to inform this what is the problem? First, not based on what you want, especially
The point she's raising is a very important one. I will try and reiterate. She's talking a lot about specialization, and I would speak to it in 2 ways. Usually, when people some people, not all, go to do masters, they have a reason why their employer or their financier or whoever, benefactor, sends them to the university to go and do a master's. For example, they might be challenged with HTA, and then you send through a master's, and then you come back and say, that university didn't do HTA. and now all the money gone. So what she's saying first is to have a foundation, which you have to, perhaps this gives us the foundation. And then if you want to specialize, which is the second one I want to talk about, you can now go in depth to know more about that, step back, go learn the foundations, and then come back to see how you take that forward. And that second part is that some people go into master's program hoping to be a specialist in something. It has nothing to do with their employer, but they have a passion for something that might have might be sparked by the lecturers. Oh, I love the way that lady talks or something. And then the person has that interest and wants to forward that. And then once that becomes a passion of theirs, like behavioral economics, for example, or economics of crime, or economics of sex. And then the moment that comes in, they begin to say, oh, that's an area I want to specialize in. And they kind of go all out in it, starting from the core principles to the methodological issues to theoretical developments and also practical applications, etc. So now comes the question I want to ask. How then do we, maybe I'll come back to her again, how then do we structure this? Should we make this as an entry point, because we cannot cover all things in depth, and then let the person who wants to specialize then go forward? The challenge, therefore, is for those who are on the practical side, like Regis and co, who might have sent their person there for that in-depth as opposed to the basic. So how then do you balance the two? It's a very big one. I don't know how to answer that. I'm coming here yet, but I have to finish. Yes.
Yeah, thank you. We need to refine our point. My understanding is whether the master program or even PhD, there is an entry criteria. It defines what kind of background makes someone be eligible to apply for a master program. But then you need to add a section that kind of close what kind of applicants, what kind of background knowledge that you have. Because if I look at the masters, epidemiology, can really start from all the way from scratch. Someone who has something first and then build on that. So that's my first. My second point is you have first economics there, you have, economics evaluation, you have knowledge activity. I'm missing the practical application now. And this is where now HTA comes in. And now the students now see that HTA now is the application of all these other competence that they have learned, and they apply it to kind of solving the third one is the possibility of work placement, internship kind of. So they exit at some point and then they go to whether it's a business or whether it's a lateral authority, wherever they want to go. Then they do like a 1 or 2 month internship, they try to solve the actual decision making problems that are there. Then they come back and continue with the research work. So there is a possibility, the bare minimum of the course. I will include HTA, the application of all those other topics we covered, and then the practical exposure.
It's raising some things that kind of others have talked about and maybe downplayed. I remember someone asked, is HTA even relevant in Africa, or should we teach it? Remember? And then he said, well, now let's look at HTA as a way of bringing together all the things we've learned and applying it. Then the other aspect he talked about, which a colleague here talked about, is the entry requirements. We, in our own world, we have what we call Bachelor of Science or Bachelor of Arts or Bachelor of whatever honors. Maybe in the Francophone world, it's not called Bachelor of Science, it's called something else, matrice, something matrice, whatever you call it. Matrice, I know it's, yeah, I can't remember how you.
Matrice, yes.
Matrice, I'm trying to get it. Yeah.
Resource.
Correct. So there are different equivalents, and sometimes they're not equivalent, sometimes they're different. I don't know how they're structured. So how then do we bring in the entry requirements such that we know that those foundations have already been covered? If we say you should have a Bachelor of Science in Economics, again, we hope that when you did the Bachelor of Science in Economics, you did that. We're only assuming that you've done that, because some universities may not have covered that. Though you have a Bachelor of Science in Economics, but that guy has not really done anything on maybe econometrics because they never had a teacher in econometrics, something. I mean, it happens. So do we assume that and then say, well, you've had this, now start it? Well, do we go back and refresh? And then, yeah, it's...
Excuse me, John. Here we have another issue. It will depend on the university requirement. If university is in the English system or Greek system, they will not access to have someone because the license now is equal to the 3 years after the baccalaureate. In terms of other university, so we need to have some flexibility for that university. The same for the duration. For the duration, there is the law who regulate this university. They will not change their rules, their way of working. They have the master of economics.
Yes. Okay, now I hope I've exhausted there. I'm opening up now. Let me start with him. Sorry, I would have started with him, but he's been raising his hand for a long time. Yes.
Thank you so much. I wanted to,
I'm Solomon from Rwanda. I've been working on the curriculum development process. And my own experience from this, go back and think about the need assessment. And the need assessment process, in case you are engaging more people, including the university, the minimum requirements are predefined. You've got your key stakeholders on board, and once they are there, they are going just to insist on the needs they are having, particular needs. Number three, they are going to insist on the in-service staff. Because the first intakes you are about to enroll to the program, they are coming from specific offices, and they are existing offices. And remember, they are holding number of data you guys are going to use for platforms. Once it on road, they are the one holding the social security, finance, budgets, they are there. And they are not going to unload to the program. Then in case you are there on the table, since the beginning, you engage with them, you know what they need. The customization is a process very key this. Now, last but not least, remember, this program is developed to stay. To last longer. Then in case you want it, just keep in mind that you're going to keep customizing this one, including the new topics that are coming. HTA is there. What is happening tomorrow? Another one is popping. The climate, the pharmaceutical economy. Then in case you are flexible, by the way, I want to borrow that flexibility. Then the program is adapted and you are linking to existing demand. Thank you so much.
Good. That talks a lot about also the other points they raised around internship placements and stuff like that. I remember in the case of Rwanda, when they developed their own program, they have what they call field placements, which is something around that allows you to be attached to any area of your interest and then get the practical knowledge that's applicable to you, whatever it is.
I think this curriculum should not be silent. Yeah. We respect the flexibility of the universities. What I just said, send accountants with masters of public health. And maybe that explains the practice. We see that people are not that useful. So we will leave it to the universities, but we can make like the university where I trained them, like I already when I went for economics, the 3 months training in economics was mandatory. Yeah. And then it's enough for that for you to qualify masters. Because we want to get to a point that when you sound about economists, I trained in Rwanda, living in South Africa, respect you because of that. If it's too flexible, then all sorts of comments does not solve.
Now, she said something that I always have a passion for, and there's a way I used to put it. Maybe she can put it better. I say, if you go into study, if I, for example, enroll today to study mechanical engineering, I would not tell my teacher, hey, stop teaching me fluid mechanics, stop teaching me ODE, ordinary differential equations, or stop. I just come here to design how to work on my fridge. And that's why I'm studying mechanical engineering. You don't do that. But a lot of people come to study health economy to start teaching them some economics. Like, hey, this is rubbish. I don't need. But they go to study medicine and they don't go and tell, I'm not here for cadaver. I'm here to learn. You don't tell them. But when you come into economics, they are so bold to tell you, this is rubbish. If you make up your mind to be part of a profession in mechanical engineering, medical doctor, whatever is accountant, be silent and listen to what you've been taught, rather than telling them what you want to be taught, which is exactly what she's saying there. Get the backgrounds right. Yes. Right.
Yeah. And tell them that this is what it's
right.
Because they come in and say, why are you doing economics?
Correct.
Why?
Correct.
We hear it all the time.
Correct.
So let's be upfront and say, this is what you're doing.
Correct.
And then we'll get the right information.
Yeah, it's a passion I've had for many years. Yes.
I was just to read on that. I was just showing John. AfHEA, International Health Economics Association, define the primary fields of health economy and also the subfields. So, if one is to be a health economist, then all those key areas should be broadly, at least, should be covered. So, like health economic evaluation, the issue of health system, demand and supply. I mean, the core essential. So there's no way you can take those things off. Yeah, they should be the foundation of the program. Yeah.
Yeah. Yes.
Yes. My name is James Jacketti.
I told you.
Okay. So I think I get some suggestions to how to implement everything. Essential things, especially issues affecting Africa, and we need to really have one issue is efficiency. Efficiency. How to efficiently manage our resources. So it's also said. Yes, I hear that yes, that mathematics has went inside economics and made economics so complex. What is going on? As you rightly said, if you want to really help people, and 1 year or 1.5 years, it's okay. 1 year course work, and then 6 months presentation, or 75% course work, 25% presentation. It's fine. I think
great. It's not really very, very interesting there. Any other comments or yes?
I just wanted to mention about the strategic participation.
Yeah, bit loud.
The strategic participation.
Yes. And the lady is not here. No, the lady is not here. She asked.
The strategic participation allows you to look at market, many other things there. So it's good for it to remain as a growth.
Yeah. I totally agree. I was recanting her question as it went. She was thinking the other way around, that purchasing mechanisms incorporate strategic purchasing as opposed to strategic purchasing covering so many aspects, including also institutional arrangements and legal frameworks.
That used to be our big discussion. How do we phrase part of the
Yes. We discussed that even in the context of Rwanda. Yeah. Any other comment, question? I don't know how we do with time. This is almost lunch. Any question before I move on to begin to answer? Yes.
Okay. First of all, I would like to apologize for my mistake. I am French.
No apologies.
No apologies. So your language.
It's good. Okay, I would like
I'm not good.
I would like to try in English. I would like to know how do you ensure that after training, the student will be able to apply all this knowledge according to the fact that in our context there are many gaps between academical side and professional side. Did you think about including organization or private partners so that after training students will benefit the internship to increase the skill or professional skill? Because if I take, for example, my country, many people of my country, Cameroon, is self-made. Self-made. After training, we are self-made. It's sometimes difficult to meet academic side and professional side. So, did you take into account this aspect of your training?
I think there are two things he's raising there. We were kind of related. It's around practice. When he started, I was like, how do you apply all the methods? Things is like, okay, it's not possible to apply everything. But then he kind of made it crystal clear that it's about practice internship. I think internship came out there and somewhere else here. And how do we create internships for people to be able to now apply what they've learned? It's one of the things that we may word into it, but in the context of Rwanda, that I was mentioning, it's entered in as a module. So you have it's a whole module, semester module. that you have to sit in Ministry of Finance or wherever, malaria, the something control agency, where you have to apply your health economic skills. The problem is that you cannot apply all the skills. You see, you can't apply all the skills. But you may end up working in another field from even the field where you did your internship. And that's the whole reason why we teach you all the areas possible, humanly possible. And then over time, when you need to move from one to the other, you can move. And that's how economists are trained. I was trained as an economist. If I find myself today in the central bank of any country, I am an economist and I can fit in. I basically switch all my theories to become a monetary economist because I have the background. But I may not have practiced over the years. But that ability to quickly switch the moment I find myself in a different area is why we train people as generalists. Yes. So, yes, he wants to follow up. Yeah.
I would like to know if for your trainer to get this internship, or after your training, the student have to go himself to look for internship. That is my question.
You want to answer that? Yeah. Okay, yeah, please.
Yeah.
2022.
The people cannot transition from classroom practice. Now, since we have Africa, why can't you make an arrangement with governments that people are given internship opportunities? But I also want to add, because you see they're going to have capacity on the continent, also a mentorship program. That people who are willing to mentor young people can be paired with them. If I'm working on research project, I can go up to you and then I give you something. But also ministries of finance or health really be available to the young people.
Yeah,
that's what you just said.
Yeah.
I think it is a specificity of because generally people make masters specialized. But for the health economics, it's very wide. So you have to make a master's first, and after that, to choose
specialization.
Where you want
specialization.
Specialized. I think it's
yeah. Comments.
Yes, thank you. Because I was also going to say, I was discussing with our SPAC colleague on the importance of the practicum. Because we observed, I'm not in the university, but I used to be part of a research, health policy research group. I'm still part of that. Yes, I never come on. No, why I'm saying that is it's really important. This is my own story. So how I got more involved in health.
Yeah.
So I was working with a donor agency and I was doing more health systems. But in my master's, I had done health economics, economics of health policy, and I did a whole lot of things, but I had not practicalized. So working with him in health policy research group, I had the opportunity of understanding how to analyze policy. I did the theoretical one, the policy triangle, but I never practiced it. But working with the research group, so because the research was research that is tailored to policy, working with government on health policy issues. That was how I got to become more grounded. Now I'm working in an organization where we do a lot around health financing and economy. But what I noticed is that people who have trained under MPH or health economics, they lack that practical experience. So you talk someone like you mentioned, you talk to someone who did health economics, they are not grounded because there is no connection with policy realities. So on my own, I started thinking, okay, how do I help? Maybe I do some mentoring one-on-one with people, but it's not enough. We have to institutionalize it in a way that programs that are doing health economics and policy or whatever name it has, there should be some connection to industry. The industry, I mean, is the government, and there are a lot of organizations that are implementing programs. So I work with a private NGO, but we are doing a lot around health economics and financing. So if we have that, kind of incorporated into the program, where practicum is, I don't want to use the word compulsory, but it's very, very important so that the student, before they leave the university, they're already embedded. Now, beyond on the other side, from the policy side too, or the academia. So Prof he's doing all he's doing because his work is in the academia, but very interconnected with policy side. So whatever he's teaching his students, I don't want to use the word case studies. The point is that everything he's teaching is based on experience with public sector and non-public sector. So if I'm doing health economics or a program, I should know how to create a program. I should know about how to develop work plans, because those are the practical realities. How do you move from program creation, implementing a program, to evaluating a program? Because we've done evaluation of both malaria programs or policies of the government. So for someone who is there, it's important. And then we should also create opportunity for those in industry and practice to be able to provide some connection with the academia. So if someone is in the university, we can be advisor to the Ministry of Health. I think Rwanda, we're talking about that. So I think we should have that connection, handshake between the policy side, the practice side, and academia and teaching. Thank you.
Great, thanks. Yeah.
This is not where the thesis comes in. So you're working on a thesis that's connected to policy.
May or may not.
But it may not even be just the thesis alone.
So for me, that would be the win-win for the institution. You're building that practicality and also coming out with something. So let's see if we can explore that with the thesis.
I agree.
Yeah, so just one
practical.
Like just one example. I'm sorry, I'm taking time. So there's a student in University of Edinburgh. She wrote to R4D. I want to do more like a placement-based thesis. So her professor and I co-supervised that program. So because I'm on the practice side and I've been involved in research, so we were able to help her shape her thesis and connected her with the respondents within the space, because ordinarily her lecturers don't have that connection. So I was able to say, okay, because it's a purposeful sampling. So we're able to identify the policymakers, the practice people, both from government and development partners. And it was a rich experience for her. So I think we should find a way to do that handshake. Thank you.
I agree. There was a couple.
I think just wondering if it also would encourage your passionate about health economics to get work exposure before they do their masters. So I had a similar experience. I worked in health economics first before I did my master's. So when I was doing my master's, it made sense because I knew how I would apply it to the life. So maybe just encouraging.
Very important point there. We have had discussions in different forums on that, and it's mixed. Mixed in the sense that it's good for you to have practical experience before you come in, which is excellent. And then the other side, someone was like, "Oh, so what are you saying? That I just graduated and I love this field and I want to make theoretical contributions in a particular field by the modeling." Guy who is very good at some mathematical stuff and he wants to or she wants to contribute. Oh, no, you have to go get experience. They say, oh, well, that's a way of stopping me from progressing in where I want to. So I don't know how we balance that. I support the fact that you need to have experience in the health sector, at least in the health sector, because the challenge we have is that those traditional economists who are trained as economists are not, they don't have a full grasp of the health sector. So when they talk about applying economics to health, they apply economics to health the way they apply economics to some sectors where there is no market failure, which is a big problem. And we have that a lot. When you hear an economist who's a hardcore economist speaking, their language is not that understandable to the average health economist. And you begin to grapple with it. But those who've had economics training, when they speak, you know what they're talking about, but they might not get it right. So these are issues that I don't know how we can deal with it, but very, very good point there. We agree that you need to go and get, and if that becomes the case, it has to be worded into the entry requirement. Yes. And some universities might not recognize that in their statutes that what they say is you need to have a first degree of a second class upper to go into. Will the university allow you to a leeway to add your own requirements onto that to admit students? I don't know. Maybe I should speak to people who have been really involved in program development within universities. Will your university allow you to add your own? Say, well, I know first degree is okay, but plus 2 years working experience or something. Can they allow that?
The requirement.
For entry requirement?
Yes.
Okay.
Approved by the curriculum committee, this should become the requirement.
I know there are many programs that have it.
Yes, you know, provided, just like you said, the approval of the degree, okay, has that as a requirement. But before you go to the Senate, you have all that.
Yeah.
Senate gives the approval.
Correct.
But in practice, you can juggle it, you know, with your experience. That's the point. Like, you know, in those curriculum, you don't have case studies. You have case studies, but when these are things that have been developed like 5, 6, 7 years ago, and you are teaching them now. So you need to bring in modern case studies. You understand? So that's the point that. So at that level, okay, you can use the experience to navigate around. But the basic thing for the requirement, if the requirement says you must have this, you must have that before they give you admission.
Good. I think it's
but while we are discussing this, it's good because this is masters.
Yeah.
But we should also be thinking of people just going in to pick, like I said,
short courses.
Short courses.
It's coming next.
Yeah, because that's more sellable.
Yeah.
More relevant to policy to users.
Yes.
Than the MS.
Yeah. That's
they might finish the coursework as you're saying. And 3, 4 years, you have not seen the project. Somebody spends 5, 6 years doing master. Not because he has been doing it. So let's create. That's what I
know many.
Let's create that pathway for users.
We're going to deal with that when we come from lunch. The diplomas and the short courses will be dealt with lunch. So, but before we go, I want, are you responding to any major comments?
Okay, so let me start with the first one, which is in line with the HTA.
Yes, they're conflicting things. One says do it, other says don't.
Yeah, we have it in the curriculum, and we captured that under cost effectiveness analysis. Within that, we have HTA, which is treated under it. So it's basically captured in the curriculum. We have it in there.
Do you also figure out prerequisites, or you're not prescriptive around, you have to have at least do this before you move on to the next, so that we know that when you're doing that, you should have done something else that requires, you know?
Yes, but for now we don't have it.
You don't have it, okay.
You want to define what you say. You have HPA and economic effectiveness analysis.
And economic
HPA is an application. Economic evaluation is EPC, you know, clinical trials, you know, if they not be there, it's broader than.
Okay.
I remember I remember during the Kigali meeting, we are going to emphasize, because as you said, it's beyond, it's a broader when you are talking about the HT. So we had that discussion. I think that if someone is doing it in the cost effectiveness as one, then we should not have to have it in the short course. But I think we completely get your point. Like, it is a broader, and then you need to stand out as its own, but depends on short course or whatever, depending on the need. Yeah.
Let me quickly say, adding on to that, what we did in the case of Rwanda. In Rwanda, we put it under what we call if I get it right, advanced topics in economic evaluation. And under the advanced topics, we have the standard cost effectiveness, the standard, we talk about HTA, and apart from the standard cost effectiveness analysis, we also had extended cost effectiveness analysis. Under the advanced topics, there's extended cost effectiveness analysis, or there's another term, we call it and then there's the HTA and a couple of other including some kind of sensitivity analysis, something of that nature. We are really covered under advanced topics. So what we foresaw was, depending on who is teaching it and the need, sometimes it may, if it's too heavy, a program that they need to do within 6 weeks or whatever, you kind of balance it to see whether I bring in the advanced ones or not, or tell them there's a short course. You can take up that short course if you're now interested in this and it's offered. Like you said, yeah. Any other comment? Oh, you still want to comment?
Yes, I mean, my worry is, we are starting fragmented. There's a big movement on HTA. Now, if we have master programs on that economics that doesn't really give that weight to HTA, then we are risking a situation whereby we have this group advocating for what we are doing, and another group advocating for HTA. But essentially, these are the same. So we need to emphasize that HTA is the application, the analysis, economic budget impact analysis, social desirability, social suitability. So to me, to be very useful, if we start to make sure our graduates from master graduates see HTA as applications of these fields, you put them together, it's a new intervention, look at the effectiveness, that, everything. So that's why I put it more as an application of all these.
No. I think it's totally understandable. Yeah.
I have a suggestion, because now I see trying to be practical. And you said, I don't need to know everything. I don't need to know everything. Is one possibility that we can create minor process or major process. We have a core process, but also implement when it reaches to active process. So that we have, you can say, okay, I have some people who came from Ethiopia, who come from Senegal, who can master HTA, which means that we have a source of something to support your initiative, for example. You have someone who can master econometrics, because currently we are moving towards now analyzing our series analysis to know how we can forecast our modeling. So I think if you can create that pool of analytics, specialty, we have the people who are going to master on estimate public. So I think we can look at in a way that we are not forgetting those people who want to do this. And someone who will see our curriculum, see it's our strongest curriculum in Africa, which means that if someone studied with that curriculum, there are two people who have qualified this and this. So which means that it's like, as I said, we are creating a competitive curriculum better than creating a room where people can say, okay, this is a very curriculum, why do this?
Yes.
And from my understanding, I see that HTA is so it's a way where we debate always concepts, equity, and I think that was always showing that we make a relationship with these concepts.
No, very, yeah.
In fact, I think it was included, I think I was discussing as an elective during the discussion, so that anyone who is interested to dive more about the HTA's application, then it's right there. So it's included, but we included it as elective. Yeah.
And it also comes up, HTA exam, it also comes up in health financing. See, the beauty of it is because an application, it comes under health financing when we talk about benefit package design. So when you're doing benefit package design, it's also worded in there because HTA is also one of the kind of criteria that you use for health benefit package design. So knowledge of it is critical. No one is, it's kind of everywhere. So it's not just that it appears under economic evaluation, but what we plan to say is it has to be taught somewhere and applied everywhere else. And the only place we felt it was possible to be taught before you apply it. And that's why I remember I talked about prerequisite, because there's something you need to know to move into the rest. Is it has to be introduced somewhere, but its application will now come with health benefit package design, with even intervention in terms of implementing a particular program or intervention. But it needs to be like the core principles need to be taught somewhere as basic principles, then applied in different aspects. If that helps clarify issues. Yes.
Mine was just to invite there is an, last year in HTA, the Health Technological Assessment meeting, we discussed a number of recommendations. And from there, not only their priority setting, but also resource optimization. Then in that case, the health benefit package design, etc., they are included there. And we can note that, and then we will see how applicable each and every site is.
It's like teaching regression analysis. You have to teach the core of regression, and then you have to apply regression analysis wherever you want to go apply it elsewhere in your life. So I know I might or we might be standing between ourselves and lunch, so not just me. I don't know where lunch. Oh, I should know. At the restaurant. Yeah, correct. Yeah. But before we go, before we go, I know there are some
about
last.
I think so maybe there was a question about the internship, mentorship, those programs. So I think still we'll flag it. I think even last year we had that in our work plan as a division. So we'll push for that. So it will not be hanging there. So at least we need to engage. And then that's why we are also planning to work on mapping of the existing capacity to connect those dots. So I think that's still a work in progress, depending on the availability of the funds. Sure.
Oh, okay, right, sir. Yeah, that's right. You also remember.
And the coupons are
the coupons will be given out by ushers at the restaurant.
Okay.
So you just go where you came in this morning. You just go across the road to the hotel. There will be ushers directing you to the restaurant.
And for the mosque next to and behind me, there are two angles for those people.
Okay, that's great. And what time are we going to?
So we'll be back at 2 p.m. Continuous. So we have about.
So what are we going to do? The next section.
Okay, I thought you all have the agenda. If you, hold on. If you don't have the agenda,
we need to project it. Yeah. I think we do have the full day.
So the next, when we return, we're going to now focus on short courses, diploma or short courses, fellowships, whatever we call them. And
we don't have to allow possibility of this stuff here.
Okay, good. So we can stop, we can leave them here, they are safe.
Yeah.
By his words, not mine though. I don't come back and say, John said, disclaimer.
So John, this is the schedule.
So this is the schedule. Please take a look. When we are back, we can expand it a bit.
Expand it.
Yes.
After lunch.
After lunch, we're going to do draft presentation of diploma and short courses, and we go into discussions just like we had here, and then we'll talk about the frameworks and the general discussions, and we can close. At least we are good with that.
Yes.
So, bon appétit, tout le monde.
Thank you.
Good. Come, my boss. Somebody delegated is my boss. Somebody delegated is my boss.
Yes.
Oh,
Yes.